Okay, good morning to everybody. My name is Herman Enoch. I'm the Marketing and Communications Manager for FEM. It is 9:30 on my laptop, so I think we're going to start our session. So a very big welcome to all of you. I see tons of questions coming through, so good morning to everybody. I'm not going to do the official welcome. I'm going to leave that up to our CEO, but just a few rules. In terms of the actual webinar, this is FEM's first webinar, and with the help of Sayosh, we've getting this through to all of you guys. So a big thank you to Sayosh. And before the questions start coming through, we just would like to remind you that this is a recorded session. So everybody will have access to the links. We'll make it available via the Sayosh platforms and the FEM platforms, which is our website. You'll see the FEM details on the slide behind me. All right, so just to take you through the day, it's going to be a rather long morning. I think the good thing about virtual events is we don't have to do the health and safety talks, but you guys listening to us can familiarize yourselves with the health and safety protocols wherever you are. A very quick run through to our events for today. So we'll be listening to a few expert speakers. We'll start off with our very own CEO, Jacqueline Michelangelo. We'll go on to our National Claims Manager. And then we have Professor Rajan Naidu, Garth Hunter, and we'll end the day with Neil Enslin. I will be introducing each of the speakers prior to them coming on. And to start off the events for the morning, I'm going to hand over to Jacqueline Michelangelo, who will do the official welcome. So Jacqueline, I'm going to hand over to you.
Thank you, Herman, and good morning to everybody who has joined us from different parts of South Africa and indeed across the continent as well. As Herman indicated, this is our first live webinar as FEM, discussing a specifically important topic in the context of COVID-19 and the impact on the construction industry. We are proud to have partnered with Sayosh on this journey. We not only partner with them for this type of instance, such as the webinar, but they're a grant recipient of ours in terms of driving health and safety within the construction industry. I'm also aware that IOSH UK has extended this invite to its members across the rest of Africa as well. And we're looking forward to continuing to work with IOSH as well. Just in the context of maybe giving a little bit of background in terms of FEM, because I do know that not everybody might be familiar with who FEM is. So we were established in 1936 and we provide workmen's compensation cover to the construction industry. In terms of industry classifications by the Department of Labor, that's Class V. So what that means is that if you're in the construction industry, you can either take out cover with FEM or you can take out cover with the State Compensation Fund. We've got a strong legacy in terms of providing workmen's compensation, having been at it for more than 80 years now. And we're proud to be able to provide that cover to more than 5,000 construction companies that cover in excess of 300,000 employees. And we've got our regional offices in Johannesburg, Durban, and Cape Town. So I think in the context of why we wanted to focus on COVID-19 and in particular, I think it's fair to say that COVID-19 has had an unprecedented impact on our lives in general and on the world of work in particular. I was looking at some ILO stats that were indicating that as at the end of June this year, more than 93% of the world's workforce was in some form of lockdown. Yeah, so that has translated to an increase in unemployment and indeed in underemployment as well. Sadly, it's also translated to reversing some of the gains that we have achieved in terms of gender diversity in the workplace, because women have been disproportionately impacted by COVID-19. So South Africa, obviously, we've not been immune to the impact of the pandemic. And we also in our lockdown, and while a lot of us can work from home, there've been a number of people who have had to go back into the workplace. And the construction industry is one of those sectors that has been back at work since the 1st of June. I think it's fair to say that for a lot of the construction industry companies, we welcomed this easing off the lockdown. There was a lot of work that needed to be done in terms of making sure that the workplace is ready and that we could ensure that employees are safe from COVID-19. And I would like to just point out here that I'm completely appreciative of the collaborative effort that had to come from a number of industry stakeholders to lobby with government to ensure that the construction sector can go back to work. I think within that context, we do need to appreciate that the world of work was an unsafe place even before COVID-19 became a reality. If you look at what the International Labour Organization says, more than 2.8 million men and women die from work-related injuries on an annual basis, and more than 370 million also suffer non-fatal injuries in the workplace as well. And it's the construction industry is one of the more dangerous sectors if you're a worker in that space. I think it's appropriate that maybe I share some insight on that basis, and I'll be very brief on this. But if you look at our own statistics as FEM, and as I indicated, we do cover about 5,000 plus construction companies, and that ranges from big employers to small employers. If you look back all the way back to 2000, we had an accident frequency of about 6.82%, which means that close to 7 out of every 100 employees amongst those that we cover in the construction space would suffer a work-related injury or illness on an annual basis, which is quite high. We have over the years seen that reduce quite materially. And last year, we were looking at about 2.5% in terms of 2.5% in terms of accident frequency. And that has been as a result of a concerted effort from a number of stakeholders, to ensure that we can reinforce, drive, and have workplaces that are safe for workers, obviously coupled with even tougher legislation and regulation that drives health and safety in the workplace. Further, to just share a little bit around that, we struggle within the construction industries from a couple of trends in terms of the factors that drive accidents in our space. And I've shared a couple of insights in that regard in terms of these slides. Our workers are extremely exposed in the context of a lot of them suffering injuries as a result of being struck by or struck against specific objects. And combined, that's looking at around about 47%. Interestingly, in as far as diseases are concerned in the construction industry, they account for a much smaller component of the accident frequency that we see. Only about 0.11% of accidents result in industrial diseases within the construction space. So COVID-19 is likely to change that quite materially, and only time will tell as we see out the rest of this year and beyond, where COVID-19 still remains a risk that we have to contend with within this sector. And my colleague Jacqueline will speak about that a little bit more. Sadly, in as much as the first half of this year, there was a period of time where the industry was in lockdown. And in particular, if we look at April up until the lockdown was eased on the 1st of June, we would have anticipated that obviously there wouldn't have been a lot of work going on during that time. But for the first half of the year, we've already seen more than 2,000 accidents that have been reported to us as FEM, and sadly, they've been 10 fatalities. And I think I always reinforce that these numbers sometimes can dehumanize the fact that behind each and every one of these statistics, there's a worker whose life could have been permanently impacted, or there's the family whose lives may have been permanently impacted because they've lost a loved one and a breadwinner. So I think for me, it's quite important that as we focus our attention on COVID-19, and indeed together our concerted efforts towards ensuring that workers are safe and that work resumes on a risk adjusted basis, we do not lose sight of the fact that there are other perils that are facing workers in the construction sector and workers in general. And we need to make sure that we keep our eyes on that as well. And do not lose some of the gains that we have made in terms of ensuring the lives of workers are protected and towards the ultimate objective of zero harm within the construction sector. I wanted to just point out as well that all of these statistics are available on our website, www.fem.co.za. And indeed, you can look at these statistics from different angles. So I've just extracted a couple of interesting aspects that I just wanted to share as part of my welcome today. But just reflecting on our session, I'm really grateful for the lineup of speakers that we have. And Herman has spoken to who they are and what it is that they will be presenting. I think the topics are extremely relevant in terms of empowering those of us who are on this webinar with insights, with practical tools around trying to mitigate and navigate COVID-19. So I'm looking forward to the discussions in as much as everybody else is. I also do want to point out that we are going to be having a follow-up webinar on the 29th of June, and that is next week, Wednesday. A great lineup of speakers as well scheduled for next week, and I've got them there. And indeed, the invite will go out not too long after today's session as well. So I invite you all to join us for that too. So without further ado, I'm happy to hand back to you, Herman, so that we can get the real experts to come and speak about different issues and as far as COVID-19 is concerned.
Fantastic. Thanks for that welcome, Andrew. Okay, we're going to move straight on. And our first speaker that we have is Jacqueline Michelangelo. So Jacqueline is FEM's National Claims Manager. She's rather small in stature, but one of the most powerful women I know. We've had many a talk together, but she's really knowledgeable, hence that being the National Claims Manager. Just a little bit about Jacqueline. She has a BCur degree from UNISA, a diploma in occupational health nursing from WITS, National Diploma in Health and Safety Management from NADSAM, and which is UNISA, and she's also completed her LLB. So she really does know what she's talking about. She's got more than 25 years experience in occupational health, serving in different health and safety forums like the Railways Safety Regulator and the Compensation Fund technical structures. Jacqueline's going to talk to us about the COIDA requirements for COVID-19 claims, and she's going to also take us through a few case studies. All right, without further ado, I'm going to hand over to Jacqueline. Jacqueline, all yours.
Hi, good morning, everyone. Thank you very much, Herman. I'm just going to share my screen. Okay, my topic today is actually to try and enlighten South African community, construction industry in particular, about the approach of the compensation fund to the COVID-19 claims. My name is Jacqueline Michelangelo, as Herman has already indicated. And what is important is based on when it first started.
Hi, Jacqueline.
Hi.
Apologies, my apologies. Can you make your presentation full screen for us, please?
Okay, thank you.
Perfect,
All
thank
right.
you.
Okay, basically is we have, there was a circular instruction that was released by the Compensation Fund in March, which serves to address the COVID-19, contraction of COVID-19 in the workplace. And safe to say that the criteria that we have in that circular instruction, which was signed by the Commissioner on the 20th of March 2020, it is based on the 4 pillars. One of the pillars being the definition of the COID itself, of the injury on duty itself, whereby it must have risen out of and in the course of employment. I just want to pause a little bit to explain what out of and in the course of employment means. I know that we do have experts that will elaborate more in terms of health and safety, but I just want to give an example to say, when you say it is in the course of employment, we actually saying that you got injured during the period where you were working and doing the job that you are employed to do. But when we talk about out of employment, there must be a connection between what you were doing and your workplace environment. For instance, if you are in the workplace and suddenly there's a bomb and you get banned or you sustain bans, then that we will consider out of the course of employment. And one other example is actually, which is very common, is when the employer has placed you in a geographical area which is not necessarily where you stay. And in that case, we say it is a positional risk. And anything that happens to you while you are there, for instance, you are placed in Ghana for a project, anything that will happen to you at that place because you are not in control of your environment, we will take it as out of the course of employment. The second pillar that we'll be looking at is the source or the agent. And also this is also in line with the COID Act, whereby there must be a specific source or an agent that has caused you the disease. In other words, when you look at COVID-19, we are talking about the index person, the person that came with that in the workplace and that subsequently infected you. That person must be identifiable. The third pillar is there must be a close contact as opposed to a casual contact. In other words, we cannot say that you were passing by and greeting someone in the workplace and you know that that person tested positive, suddenly you tested positive. When we look at the close contact, we're looking at someone that you have spent at least 15 minutes or more with that person under enclosed environment or on a face-to-face contact. The most important with regard to COVID-19 claim is the pillar number 4, which we are saying the occupation must be an inherent requirement of the job. I will elaborate more on this one on subsequent slides. However, I need to say that you've got no control of the situation, the environment around you, and that environment is a very high risk area. It is some sort of infested with the virus. It is expected that the virus is everywhere in that environment. So based on that, I will concentrate more on the occupations because according to circular instruction, they have classified occupation into 4 categories. The first category being the occupation where there is very high risk of you contracting the virus. In this case, it's easy when you look at other sectors to look at the health professionals. They've got no control. It's an inherent requirement of the job. They need to be in the hospital. They need to be in the clinics. And however, when we align it to our construction industry, we are actually need to look at it. For instance, I'm just going to make an example of the first aider that attends to someone. It is an emergency. However, we are going to, when you submit the claim for first aider, we will be looking at the incubation period or the chronological sequence that led to the first aider testing positive. We're looking at occupational health doctors, occupational health nurses in the construction industry. We're looking at people that might be handling humans as specimen, and the people that actually dealing with the bodies, human bodies directly. The second one, classification, we are looking at the high risk exposure. And this category, we are also likely to accept the claim without necessarily identifiable source. In this category, we are also looking at the jobs where there is a high potential of exposure to a known or suspected case. We're looking at the people with healthcare delivery or the support staff. For instance, I'm just gonna make an example that the cleaners in the hospital, in the clinics, they fall under this category. The technicians that will be repairing lifts in the hospitals, they may fall under this category. In other words, not necessarily the health professionals per se, but people who are in support of the health professionals in that environment. The third category, it is the medium risk. And I think this category is the one that affects the construction industry the most. This case, we are saying the medium risk, each case will be adjudicated based on supplied information and the information at our disposal. I must state that in terms of COID, we do have cases where we get very superficial information. And in that case, we are really unable to adjudicate properly. And only when we repudiate the claim, now more information is coming. I'm gonna urge and request that we complete the forms, which I will show following the slides, that we submit them in full. And even if you are not able to submit them, at least acknowledge by putting not applicable or something like that. So the medium risk, we are looking at occupation whereby the employment is an inherent requirement of the job. And they require, you've got no option, but it requires close contact with people outside your work sphere. And these categories, we're looking at contact travelers, the community field workers, people that are working within the community. I will look at people who needs, to actually work with sewage and human waste, and even the COVID coordinators, because they need to be there taking temperatures at the entrance. And it's very difficult, much as we apply all the safety measures according to the regulations. It is indeed very difficult for this category of employees to actually be 100% safe to say they've applied the measures and they are not going to contract the virus. And based on that, we're also looking at security officers and people in the hotel, the receptionists. This will be the people that falls under the medium risk category. And safe to say that anyone that has got no option but to interact with the community whereby the regulation cannot be properly adhered to, we will look at that case based on available information and on its own merit. The last case is the one for the low risk, where we say these are the category of people that basically we will require to know the indexed source or the source, the person that actually infected you. And I must state that we know that according to the circular instruction, it is a requirement to actually submit the report of the source or the index person. But with time, we have realized that this might be a breach of medical information. And all what we require is the name and the surname of the source and the date, because the date is very important that we can track down to say it's within 1 or 2 weeks. Therefore, it is possible that this person is the source to this individual that is submitting a claim. The adjudication is also based on the direct contact with the positive person in their workplace. you may find that the initial person, the index, what we call the index source, does not know where they got the disease from. However, due to close contact or sharing offices, the index might not be covered under COIT, but the second person and subsequent individuals that, based on the information that we receive, are likely to be accepted. It is very important that the employer comply with the regulation, and I will state going forward why it is important to do that. So we have given example of those individuals which are like office workers and machine operators that working alone, you know, with that machine, you working with computer technician, you repairing to computers. So it is very much possible that you can practice the regulation. What we have done now is to actually display the information, as our CEO has already stated, where you can source the forms that I'm going to project now, where you can source them, and where you can submit the claim. The claims can be submitted to FEM registry at fema.co.za, as it reflected on the screen. Now, the first form, which we are all familiar with, because it is the same form that is used for occupational diseases. It is the declaration by the employer. It's got a page 1 and a page 2. And this form basically, because COVID-19, it's classified as an occupational disease. To a certain extent, we are looking at the inherent requirement of the job, which complies with the Schedule 3 of the Act. So this is the form that it serves as an employer's report of accident, but under occupational disease that we will need. And subsequent to that, there is this medical exposure and medical questionnaire form. This is a very, very important form because it sort of helped us with the chronological sequence that led to this individual testing positive. It also identifies who the source is. Please do not be disturbed because this form still says we need the report of the source. And I've just explained that it is sufficient to just submit the name and the surname and the date in which that individual tested positive. Safe to say, we are aware that currently with the changes that are happening, because this condition is new to all of us, people do not necessarily receive the paper, the results in a paper form. They actually get SMSs, but that SMS is important that you attach to the form and you forward to FEM. This form is basically displayed it mainly relates to health and safety. However, in terms of the COIT Act, this form is very important that to actually protect the employer when it comes to Section 56. Section 56 is where it's a section whereby the employee can come back to us and want to claim more compensation due to the negligence of the employer. So if we do have this form, which is a risk assessment form, that is properly completed, we can use it again as a defense for the employer not to award more information. And it is very important that we have it at our disposal because it also shows us that you have actually complied with the national regulation as it is mentioned by COGTA. I'm just gonna move now to just maybe explain what happens should we adjudicate on your claim and your claim is accepted. Firstly, we do know that testing is very much unlikely that you know where you got the disease unless someone comes forward, but the initial testing will be paid, may be paid by the employer. It's not compulsory because we know that the testing is also available in the public sector, but if you need to go to the private sector, the employer can pay or the individual can pay for themselves. And FEM, once we accept the claim, we will need a receipt to reimburse you accordingly. Of course, we are going to reimburse you in line with Section 73 of the Act, whereby we will pay reasonable costs thereof. But I guess at the present moment, safe to say that the costs are, as projected, are very reasonable. So the follow-up testing, in the beginning, we knew that you had to test before you go back to work. It's no longer a requirement, it's no longer mandatory. However, should an employee whom we have accepted the claim find themselves being able to test, to do a follow-up testing, we commit that FEM will pay that testing based on the first test and the last test that you have done. When it comes to temporary total disablement, this is the wages in simple terms. This is limited according to the circular instruction. We will pay wages or the temporary total disablement wages up to 30 days. That is, if there are no complications to this case, you are expected, you positive, you quarantine, and FEM will pay the wages 75%, of course, as per COID, up to 30 days. In a case where there are complications and the employee is hospitalized, then we will treat this case as any other injury on duty, and we will pay the hospital bills and everything else that is related and the complications, any other condition that may arise during that period, and we will pay up to discharge. And after discharge, the employee will have to submit a medical certificate that indicates that he is fit or she is fit to resume work. Of a serious note is the following point of self-quarantine. We've had a lot of employers asking whether we're going to pay if a person is self-quarantined. Remember that in terms of COID, it's not yet an injury on duty. We cannot claim injury on duty when a person is a contact or need to self-quarantine. In this case, the employer may be responsible for remuneration in line with the national regulations. FEM or the compensation fund per se does not get involved in cases of self-quarantine. Now, when it comes to impairment, impairment can only be determined 3 months post the recovery. And in this case, we have seen now lately that especially the young people, they do suffer from, some of them suffer from asthma, shortness of breath. They need to be on chronic medication. For how long, we don't know at the present moment. However, we are saying that we will cover that chronic medication should there be complications, and we will pay any other medications that the doctor might recommend in line with the initial disease, which is COVID-19. When it comes to death benefits, we are going to apply the death benefits on accepted claim based on COID, and it will be treated like any other benefits when a person dies on duty. In other words, the widow, the widower, they will be entitled to benefits. The children under 18 will also be entitled to benefits. And we have just decided to make case studies just to explain some of the cases that we come across and how they were adjudicated. And this is not conclusive. It is a difficult task to adjudicate on cases, but we purely depend on the information from the employer. So we are looking at our case study 1, whereby the employee is a technician. This person repairs the lifts, and we get a report that he tested positive. The case history is that he was repairing lift at Somerset Hospital. In this case, we are not even going to ask for a source. We are likely to accept the case because the employee was exposed to a high-risk area. We've got a second case study, which is similar in occupation. Occupation is of paramount importance when you submit these cases. And these individuals goes in the community, do house-to-house repairs, active in the community. The adjudication of this case, it firstly is that the job that is doing is not inherent requirement. In other words, does not have to go to an environment where it's highly likely that they can get. And the national regulation in terms of health and safety is possible to uphold. And we will need also a proof from the employer that they did comply with the requirements, including that risk assessment form. And based on the information, we will either repudiate or accept, but if there isn't enough information, we are likely to repudiate this case, because the individual can go to any other houses, they've got different modes of traveling, and they go to the malls, and that's a person can get this virus anywhere in that case. Case study 3, we are looking at a construction worker working on the construction site, and they are traveling in groups. It is very important to note that if the vehicle or the transport is provided by the employer, and the construction workers specifically, they are traveling in groups, it is likely that any case that arises from that, we will accept, because as soon as the employee gets into that transport, is already on duty. But we will need to indicate the first case that was detected, which might be a person might have contracted it externally. We are likely to repudiate that case, and the subsequent ones, which are now the contact to this index person, we are likely to accept. We will need the positive results in each case to be submitted on a separate ER. It's not like a collective ER for all contact people. So the source actually must be identified at work. Case study 4, we are looking at a construction worker on a construction site, and the ER says it tested positive. And on the ER, where they say contact, it says touching all surfaces. You know, this case outright is likely to be repudiated because we touch surfaces everywhere we go, even outside the work environment. We just thought also it is important to just project and portray what has been happening to date. The cases that we have received, I must state that these cases does not necessarily indicate the employer's report that we have received. The employer's report, I think there are far more than the numbers that are reflecting here. However, these cases are the ones that were submitted with positive test results, COVID-19 results. And these cases are as on this, at the 17th of July 2020. We have received 49 cases, and I've just broken it down according to provinces. And out of those 49, we've only accepted 14, and we have repudiated 19. And there are 16 more cases that are pending, which when we adjudicate on it, we feel like it's likely to go either way. Herewith are the contact details that should you need more information, you can email to inquiries@FEM, and it's reflecting our office numbers there. And as our CEO has indicated, we do have office branches in Durban, Cape Town, and Joburg. And we also have after hours contact numbers. I must say that this number, if you dial it, it will reroute you to one of the managers who will be able to assist you. Thank you. That's all about my presentation. I'll hand over to you, Herman.
Thanks, Jacqueline. That was a great presentation. I know we have to field quite a few questions on COIDA, and we try our best to get people to understand. I think the easiest way to understand it is that we have to trace the source back to work, and as we're all aware, that's probably not the easiest thing to do. So Jacqueline and her team are the experts at this, and what we'd like to encourage everybody is, if you're not sure, to complete the required documentation and send it through to Jacqueline. Just a quick update. In terms of questions, I've been receiving quite a few messages asking me why it's not interactive. So we do have the chat facility. And if you want to pose your question to any individual, any of the panelists, you're welcome to put your questions down on the chat. We do have people monitoring that chat. I did also receive a few email questions, and a lot of the questions were related to sites being shut down because of COVID. So we've got to just bear in mind that we do only the COIDA part of it. So this is what we would do is we would address all the individuals that have contracted COVID, and we don't necessarily deal with the site shutting down. That is more for the Department of Employment and Labor, so the new DEL. Okay, we're going to move on with our program. I see we're doing very well on time. So we have 3 very exciting poll questions that we'd like your feedback on. So I'm going to ask Gareth. Gareth, can you run those polls for us now while I start the introduction on our next speaker? Okay, so coming up, we have Professor Rajan Naidu. He's a professor at the University of KwaZulu-Natal, and he's going to talk to us on worker exposure and workplace risk. So just a little bit background on Professor Naidu. He's an occupational health physician who served as director of the IHU and was previously heading the occupational health program of the Department of Community Health. Professor Naidu received his occupational health training at the University of Cape Town in 1994. He subsequently received a master's in public health in 1998 and a doctorate in 2002, both in occupational medicine from the University of Michigan in the USA. His research interests are occupational and environmental respiratory disease and dose response models. In 2005, when occupational medicine was finally recognized as a specialist medical qualification, Professor Naidu was one of the first to be accepted as a specialist by the Health Professional Council of South Africa. In 2005, he was promoted to associate professor in occupational medicine. Professor Naidu was appointed chief specialist and head of department in April 2008. With the restructuring taking place in 2012, the DOEH became a discipline within the School of Nursing and Public Health, and Professor Naidu became the head of discipline. So welcome, Professor Naidu, and I'm going to hand straight over to you.
Sorry, Prof, it's Gareth here. Herman, let me just share the poll results.
Sure.
Do I have to stop sharing my screen?
That's okay, Professor. You can just hang tight for us. Thank you. Just showing the results of the first poll question. Right, thank you, Professor. You can continue.
Thank you very much. I'd like to extend my thanks firstly to the organizers, FEM, for inviting me to this presentation. I think given the crises that we're facing in the country, particularly in the settings, in workplace settings, this is a very opportune time to discuss these issues. And it's very encouraging to see that both SIOSH and FEM have partnered together for these sorts of initiatives. And I'm also looking forward to the program that they've planned for the next session. So thanks very much. I hope that I can contribute to the knowledge of participants that are on this meeting, in this conference, on these issues. We've been talking a lot about these for some time, for the last few months. Things are changing as we go along, but some of the core aspects of the epidemic still stay the same. I've tried to make sure that my talk is directed towards the construction industry with some aspects related to the industry itself. But I think I'd like to make it clear that I'm no expert in the construction industry, and I fully appreciate that you may know more about some of these aspects than I would. What I want to focus on is looking at how workers are being exposed in the environment and the sorts of risks that they're likely to face. To be having a glitch about moving my screen. Okay, so clearly we are in a situation where, as in terms of how the epidemic impacts on us in the workplace, it occurs at several levels. We know that workplaces are going to be the source of increased risk of infection. We also know that apart from workers becoming sick, workplaces are going to be contaminated areas. Together with this and together with the contamination of workplaces, we're going to become increasingly anxious about our place in our position in the working environment. So we have concerns about workplace productivity, but at the same time, we also have concerns about if we come to work and if we are exposed to fellow workers, what are the chances that we're going to be taking the virus back home to our loved ones? So this further increases the anxiety that we feel. And it is all of these things that we need to start to address when we're speaking about how do we protect and how do we manage workers in the working environment. But then if we start to think about the construction industry itself, does it present with a greater risk than, say, any other working environments? And if so, why? Or if not, why? We know that the risk of exposure is not the same for all workplaces. It's going to vary not just by workplaces, but even within workplaces, it's going to vary according to job descriptions. And even within that, it also is going to vary geographically. So for example, if right now, if you're a construction site in Gauteng, your risk is going to be far greater as compared to if you're on a construction site in Mpumalanga, because of the incidence of infection varying across these two provinces. So we know that within a working environment, the risk is based on what is the likelihood of an infected person being in the work area, how close are fellow workers to this infected person. And in this case, an infected person can be both a fellow worker or a client that needs to be in the working environment, and how long a person has been exposed. So looking at these, a number of agencies globally have started to look at which are the most riskiest working environments. And this graphic here comes from the US, from their Occupational Safety Health Administration and their research teams. And I know this is a busy slide, but it clearly shows the x-axis is showing you the increase in risk. The two y-axes are showing you the increase in income for the different jobs. And both of them are showing you the increased risk in income. So giving you a sense that within jobs or within different types of jobs, it varies according to income. The construction industry is located, you won't find it specifically here, but it's located in this sort of area around this, score of 30. When they looked at rating the different types of jobs, the construction industry was rated a score of 36.1, the riskiest job being 100. Okay. So in a sense, if you look at the table, it's also placed in that sort of category. They looked at what's the sort of exposures that one could expect in these different industries on a monthly basis or on a weekly basis. So it is expected that on a monthly basis, there's an 8.3% chance of at least one exposure per month in the construction industry or a construction worker. This is now in the US. So clearly this says that not all jobs are the same. If you look at the data from the United Kingdom, once again, construction, we know that workers in the healthcare industry are going to be at highest risk and therefore will have the highest levels of infection. But if you look at the construction sector, falling towards the latter part of the curve. So the question for us now is, given these pieces of information that we've seen from North America and Europe, can we expect the same sort of scenario to play out in the construction sites in South Africa? I'm going to argue more for caution and possibly more that this is not likely to be the case, that we're going to find our workers at greater risk. We know that the construction industry requires people to work in close proximity for protracted periods of time. That applies across the world. Small groups of people undertaking specific tasks, also typical for across the world. But I don't know the industries in the UK and in the US. I do know the industry to some extent in South Africa. It's largely characterized by casual workers, informal piece workers, and lots of subcontract work. This means that unlike in a industry, for example, a manufacturing sector where the person who comes to work every day is the same person doing the same task at the same piece of machinery, it may not be the same on a construction site. You're going to be getting subcontractors who will come in to do a small piece of work. You have no idea where that worker was a week ago. And how do you monitor? How do you do screening for that individual worker, not knowing where they may have been previously? So these become challenges that we need to face. And I'm suggesting, and the data still has to come through, it will be very interesting to see with the compensation data about workplace acquired infections and how these will transpire in our workplaces. But I think this is part of the reason why we need to start understanding the numbers and the data very quickly in our workplaces. So clearly, if we want to protect workers in our settings, there are certain things that we've got to do. And basically, some of our tasks are, one, we have to screen before work. I'll speak a little bit about screening and the issues associated with screening just now. Then the next issue is, if we've not been able to stop and screen out all the people who are positive, we're going to have outbreaks in our workplace. The outbreaks may be one worker or it may be more. And how do we manage that? Then you've got the issue of managing a positive worker. How do you manage a worker who becomes positive either in the work environment or from being positive from exposure in the communities? Workers are going to be isolated if they've got the infection. They're going to be quarantined if they're suspected to have the infection. These workers need to come back to work. You need to have a process by which they come back to work. And then finally, we'll spend a few minutes just looking at the management of vulnerable workers. Sorry, my screen doesn't seem to want to shift. Okay, so let's talk about screening. When we're speaking about screening, the first thing we need to do is understand why we're doing screening. The purpose of screening is purely to identify symptomatic persons. That is why we do screening. Then the question comes up, if it is to identify the symptomatic people, what percentage of people who are infected are likely to present with symptoms? Different studies give different reports, but basically you're looking at a range of anything between 5 to 80% of people presenting without symptoms. The average tends to be around 50%. So if we're thinking of trying to use some sort of working rules, we can assume that 1 in every 2 people who present to our workplaces without symptoms are likely to be transmitting the disease. Okay. So the next question is, how then do we screen out? So clearly our screening is only going to pick up 50% at the very optimistic level, right? So the question is then, how can we make sure that our screening is as effective as it can be so that it picks up over 50%, if that's the minimum that it does? So there's 2 approaches that we've used for screening. One is looking at objective testing or objective measures, such as the use of a temperature and or use of symptoms. Now, if you look at the list that I've got up on the screen there, if you look at fever alone is only present in 43% of those people who are symptomatic. Cough alone in 50%. But if you take fever, cough, and shortness of breath, your sensitivity for picking up symptomatic people increases to 70%. So clearly we have to use a grouping of symptoms, and you can't just ask one question. You can't just ask, do you have a fever? And then say, okay, fine, I've screened you. You've got to use a grouping of symptoms. The problem has been that a lot of us have been focusing on temperature monitoring, having somebody stand at the gate and take your temperature. Now, if you assume that 50% of our positive cases are asymptomatic, and as I indicated, up to 43% of them will present with fever. So that means that for every symptomatic person, only say about 50% are presenting with fever. So that basically means if you're only doing temperature monitoring, and if you're doing nothing else but temperature monitoring, you're going to only pick up 1 in 4 of the people that are positive. So the case that I'm making is don't only depend on temperature monitoring. There's additional problems with temperature monitoring that may make people think whether this is useful. It's around the issues of cost and quality of the equipment, calibration. There's a whole range of types of equipment on the market at the moment, and how reliable are these? How can you calibrate them? How skilled is the person that's using the equipment? Then we also have issues around external conditions. Taking the temperature of somebody who's just walked a kilometer from the bus stop in Durban as compared to somebody who's exposed to the cold in Johannesburg is a problem. What we've also seen is that there's increasing numbers of points of entry personnel that are becoming positive. And it's easy to sort of understand that they're at the front of all these enterprises, and they're taking measurements in close proximity to people who are likely to be positive. So this becomes an issue. The point that I'm making here is don't rely on just a single approach. Don't rely just on temperature, but consider the entire grouping of symptoms. And this is what the National Institute of Communicable Diseases advises. On the 25th of May, they dropped fever from the main symptom list, and they brought in loss of taste or smell. And they did this because of some of the reasons that I've already mentioned, but because fever is so non-specific. Okay, particularly as we were entering into the flu season, a lot of people will be presenting with fever as a result of influenza rather than as a result of SARS-CoV-2 virus. There are a number of screening tools on the market. There are a number of people use, lots of people use paper-based solutions, and I strongly argue against this and encourage people to use one or the other electronic screening tools, particularly screening tools in which you have control over the data. In other words, downloading something from an app store is of very little use, because basically you want to be able to use these tools as management and as for monitoring your workers. So unless you have access to the back end of the data, the tool does not become very useful in a management context. So the next area that I want to speak about is assuming that your screening is not effective. Well, we know that it's not totally effective, that 50% of people are going to come into your working place who are likely to be positive. Then what do you do when you have outbreak? So we know that these are common scenarios, and it's going to be even more common in the construction sector. A worker tests positive, but has already been at work for a few days. When by the time the diagnosis is confirmed, the worker has either spread the infection to fellow workers and contaminated the working environment. And then all of us are faced with the question, should we close the affected work area? Should we close the building? Should we close the construction site? Do we quarantine all workers, or do we quarantine selected workers? This is a sort of scenario that plays out and hopefully this animation will show what I'm trying to point out. You have a worker who is asymptomatic, but already infected, getting into the public transport, and this then transfers infection to a fellow commuter who then takes it to his or her workplace. But then our index case goes to their working environment, and in the particular section in their working environment then is exposed to other people, moves over into the communal social area, tea room, canteen, etc., and then starts to infect people in these contexts, including people that are moving around, such as the floor manager, and then you have the spread throughout the factory. But then there's some sections that are untouched, and then the worker turns positive. It's the first time that you know the infection has been brought into your working environment. By this time, the disease has spread through a large sections of the workforce. And how do you manage this? In order to be able to determine what's going on, you need to then figure out how long, what are the risk factors, where's the risk? So as I indicated here, the risk may be very well in the community, it's in the public transport, but this may be not only the case. This may be a casual worker who's coming onto a construction site, who worked on a construction another site in the previous day or the previous week and contracted the disease then. So it's these sorts of challenges that we're going to face in our working environment. So in terms of how you manage these sorts of outbreaks, we've had a number of organizations, number of government departments that have put out guidelines. The National Department of Health in the Occupational Health Work Stream has put out a guidance note. It's a very high-level document. It's not meant to be stuffed with details because the details will vary across different work sites and work organizations. But essentially, the first task that an employer must do is conduct an incident-based risk assessment. So not to be confused with the standard risk assessment that you need to do across your working environment, but an incident-based risk assessment based on the presentation of this positive case. You need to clean and decontaminate the area, and once again, doing so in a meaningful way, not just a question of spraying and fogging. Then you need to look at whether you need to improve your control measures. The critical aspect that I find very important and lacking across most work organizations is the ability to communicate the problem that has occurred to the rest of the workers. What tends to happen is people believe, oh, this is confidential, we need to keep it quiet, we need to make sure that it doesn't get out into the public domain. All you're doing is creating a whole lot of anxiety, both in the community and among your workers. And their response is, we've heard that there's a positive case, we don't know who it is, we don't know which environment, we need to shut the workplace down. As opposed to providing people with up-to-date information, what is going on, who's been tested positive, which working area, and what you're doing about it, would make people much more feel much more comfortable and reduce anxiety. So you've got, on the one hand, the guidance document from the Department of Health's Occupational Health Work Stream, but you also have got a legal requirement. Department of Employment and Labor's direction says clearly, if a worker has been diagnosed with COVID-19, the employer must investigate the cause and review its assessments and ensure that the necessary controls are in place. So this is in the existing direction from the Department of Labor. So what we need to do then is the post-exposure or the incident-based risk assessment. We conduct this at 2 levels. You assess the contamination in the workplace, and it's got to be systematic. And this is the point of trying to put this out there. It's got to be systematic. You can't just say the entire workplace has been contaminated. And then what is the risk of exposure to fellow workers? This is going to vary based on the job that people do. And then the next level is, have you had any problems, any weaknesses in your hazard control that you need to improve? So when you're doing the workplace assessment, what you need to do is you need to clearly identify the sections in which this worker was active. And through a clear history of where this worker was working, which are the different environments that he went into in the workplace, you need to then determine how you then decontaminate those areas. The worker may have used equipment that's specific to him or her, or he may have used communal equipment, for example, a tool that is shared, or things like in the construction site, ladders or any other equipment may have been shared. And which were these equipment that was shared, and are they contaminated? Then there's also non-work areas. People may be aggregating in tea areas, canteens, and other such places, ablution facilities, toilets, and these non-affected areas also become a potential source of contamination and spread of infection. But you need to systematically assess these and then determine which of these are likely to have caused exposure to other workers. Clearly, if you've got somebody, you know, it's not typical on a construction site, but if you've got somebody sitting in an office where few people gain access to that individual, and when they do gain access, they're normally engaging with that individual across a 1.5 to 2 meter desk, both wearing masks, then obviously your exposure risk is low. Then you need to decide in terms of the spread of the infection, what are the risks to fellow workers? We know that not everybody is exposed, or not everybody is at the risk for exposure. The criteria we need to consider is the proximity of the worker to the infected worker and the duration of that proximity. So how long was this person in close contact with the affected worker? And then the next thing is, during this period of close proximity, where either the affected worker or the exposed worker using any cloth masks, respiratory protective equipment, and or a face shield. So at this point, I want to emphasize that a cloth mask is not protective equipment. Bear this in mind at all times. The cloth mask that you use is to protect other people. So by no means consider a cloth mask protective equipment. The protective equipment that we speak about is your surgical masks, your FFP1 and FFP2 respirators, your N95 or KN95 respirators that are considered to be protective equipment. So based on all of this assessment, then you decide whether a person has had a high risk for exposure or a low risk for exposure. And based on that decision, you decide whether this individual has to go into quarantine and be tested, or whether this person can return to work. And we look through an algorithm in a short while. So within this context of exposure, as I said, it depends on proximity, it depends on duration, it depends whether there's any barrier screening between the people. For example, in the person engaging in an office setting, you can have a barrier between a client and a worker. Obviously not possible in a open construction site. And then you've got if people are using protective equipment, then clearly this reduces their risk as well. If both the parties were using cloth masks and they were within the 1.5 2 meter distance, then the risk is also substantially lowered. So this is the criteria that people use to determine whether somebody's been having a high risk of exposure or a low risk of exposure. And once again, it's just to emphasize its distance, its duration, and its use of protective equipment. So based on your assessment then of the contamination of the working environment and the number of workers that are likely to have had a high risk of exposure, you make a decision on whether to close or not. And once again, you consider other factors. How many workers were exposed? Was it a large number of workers? Were this, by putting these workers into quarantine, are you affecting a critical mass and therefore need to close down production or the activity? So all of these then become a decision that gets made once you have the data available to you. So we've now gone through the screening, and then because we know that screening is not going to keep everybody out of the working environment, we know we're going to get in people that are likely to cause transmission within our working environment. And having caused transmission within our working environment, we're going to have two categories of people. We're going to have people who are positive, and we're going to have people or workers who are highly exposed to this positive worker. And the question is, what do we do then? Once again, the guideline documents from the National Department of Health have put forward 4 scenarios. The first scenario is a positive worker, and it's quite clear what we do with a positive worker. If a worker informs us or informs management that he's been tested positive, the worker goes home for a period of isolation, either self-isolating, or if this is not possible, isolating at one of the dedicated public health facilities. As you can see on the slide here, I have made changes to the slide. Some of you may have heard the National Minister of Health saying that de-isolation period is now going to be reduced from 14 days to 10 days. I've not made a change to the slide only because the Department of Employment and Labor's legal requirement is still return to work after 14 days. These documents will now start to undergo changes and will revert to the 10-day guideline put out by the Department of Health. So basically, if a worker tests positive after, whether you choose 14 days, let's just stick for this discussion purposes on 14 days because that's the legal requirement at the moment. After 14 days, they can return to work. But very importantly, after 14 days of having symptoms only, they return to work without the need for being tested again. No testing after 14 days with mild symptoms. If the person has had some moderate to severe forms of the infection and they had to be admitted to hospital and they had to be either go onto oxygen supplementation or unfortunately being ventilated, then they will return to work 14 days after they've become clinically stable. So the difference here is if you have mild flu-like symptoms, you return to work after 14 days. If you've had anything more than that, you return to work after you've been determined to be clinically stable by a medical practitioner. Okay, but once again, for both of these cases, you do not require the worker to be retested. And the reason why you don't require a worker to be retested, there's a very, very good chance that they will still test positive. But by this period of time, either 10 days or 14 days, they're no longer transmitting the disease, or the risk for transmission is substantially lowered. Okay, so they will test positive because they have some element of the virus particles within their bloodstream. So you don't want to confuse yourself by testing positive and assuming that they're still transmitting the disease when they're not. The second scenario from the Department of Health is those that present with symptoms, but not necessarily been tested positive yet. So in these cases, currently now, essentially a worker presenting with symptoms, if it does meet the criteria for testing, the worker ought to be tested. If they don't meet the criteria for testing, then you need to make a determination, or a doctor needs to make a determination that this is not COVID-19, and then they will have to basically go on sick leave as per the normal sick leave process. So those are the first two important scenarios. A worker was positive, symptomatic positive, a worker was symptomatic, but yet to be tested. The third and fourth scenarios refer to a worker who's asymptomatic. But scenario 3 is an asymptomatic worker with a high risk of exposure in the work environment. For this worker, if the worker is asymptomatic, they need to be put off work and go into quarantine immediately. It would be preferable for this worker to be tested. However, under current constraints around testing, there's a challenge, and not all people are being tested if they don't have any symptoms. But so irrespective of whether they have symptoms or not, if it's been determined that they have a high risk of exposure, they need to be put off work. And if they're an essential worker, we argue that they need to be put off work for 7 days and return to work on day 8 after they get tested. But in terms of the construction, unless one can argue that somebody is an essential worker, workers would need to be put off work for 14 days. Because of the constraints on testing, it was felt within the NEDLAC structures that rather than bringing these workers back earlier, we keep them out for 14 days. This may change now to 10 days, but certainly as per the legal requirement at this point in time, it's 14 days since they've had the exposure. If the worker remains asymptomatic for this 14 days, they can come back to work without being tested. Obviously, if the worker becomes symptomatic within that 14 days, then they fall through to scenario 1 and they get tested, or scenario 2 and get tested. You then have the 4th scenario. Here you have an asymptomatic worker who has a low risk of exposure following exposure to a positive. Now, we argue that if the worker is asymptomatic and had a low risk of exposure, this worker can continue working without being placed in quarantine. However, this worker would need to be observed. You need to make sure that this worker is using a surgical mask, and this worker is not likely to transmit the infection. So you want to try to make sure that this worker, by all means, is maintaining social distance, following the standard precautions, and using a mask at all times. But there's no reason for this worker not to be working. We then need to now decide, given that we've got the workers who are either in quarantine, meaning that they're asymptomatic but suspected of being able to transmit the disease, or we've got the worker who's positive, they need to return to work. So the Department of Employment and Labor's direction says mandatory 14 days of isolation. If the worker has moderate to severe illness, they come back only after a medical evaluation. If the worker has had simple flu-like symptoms and no other severe consequences, they do not require a medical evaluation. They can simply come back to work after 14 days. The direction also argues that even though the person has come back in 14 days, they need to observe standard precautions, including wearing a mask for 21 days, because there's a small possibility that they could still transmit the infection after 14 days. And then it becomes a responsibility of line management to monitor these workers should they develop symptoms during the course of these of this period until 21 days. The next category that I want to focus my talk on is looking at the vulnerable worker. And here we're looking at how do we protect this category of workers from severe illness. Now, the concept of the vulnerable, well, not the vulnerable worker, but the vulnerable person first emerged in the Disaster Management Act regulations, where they clearly pointed out that those people who are above 60 years of age and those people with certain comorbidities are at increased risk for developing severe infection. This was then further codified in the direction, and it became a requirement for employers to actually assess workers for vulnerability. What's important to note that when we speak about vulnerability, we're not speaking about vulnerability to acquire the infection. We're speaking about vulnerability to develop severe forms of the infection. So everybody has the same risk of getting the infection. But those who have some level of vulnerability have are at increased risk of developing severe disease. And that's the concern that we have. The Department of Health Occupational Health Workstream has put out a guidance note on that, and that's well worth looking at. And I'll speak to that in greater detail just now. So who are the vulnerable workers? What are these different categories? If you are 60 years and older, irrespective of anything else, 60 years and older, fit comrades, marathon runner, you are still in the vulnerable category. If you have severe obesity, we measure obesity by the concept of body mass index, which takes into consideration your height and your weight. And if your height and weight, the index is more than 40, you are then classified as being severely obese and therefore at greater risk. So just being overweight is not a risk factor, but certainly being severely overweight is a risk factor. Then people who are maybe immunocompromised as a result of being on cancer treatment, having undergone some form of transplantation, immune deficiencies, they're HIV positive and they're not on the medication, or they're not appropriately controlled with high CD4 counts, or sorry, low CD4 counts, then these are all of concern. If people are on chronic steroid use for any reason, they're also immunocompromised. Then there's the issue of pregnancy. So there's some debate in the literature about this, but when we first put out this document, 28 weeks, being more than 28 weeks pregnant was suggested to be at an increased risk. Some of the obstetrics professional bodies are saying that pregnancy actually does not present with any greater risk than with any other normal person. Sorry, it's not abnormal to be pregnant, but a person who is not pregnant. So it's possible that when we revise this guideline, that category may fall out, but for this point, at this point in time, it's worth also taking that into consideration. Then there's a whole host of medical conditions. But once again, it's not just a question of having this medical condition. It's a question of how well is this condition controlled or not? Are you on optimal treatment or not? That becomes the important factor. For example, chronic lung disease. If you're asthmatic, you're not automatically vulnerable because you're asthmatic. You do become vulnerable if you have poorly controlled asthma, you're on multiple preventer inhalers, for those of you who are asthmatic and understand these concepts, and if you are taking oral steroids. That means you're poorly controlled and therefore more vulnerable. The same with having active TB. Having had old TB, you're not at risk. But if you have active TB, yes, you are at risk. And if you've had some sort of lung damage as a result of your previous TB, then you're at increased risk. And the same for all of the other conditions that listed there. If you have diabetes and it's poorly controlled, moderate to severe hypertension, so not just hypertension, but moderate to severe hypertension, a range of heart conditions, as well as being dialyzed for chronic kidney disease or having liver damage as a result of chronic liver disease. So all of these conditions then mean you are vulnerable for severe forms of the disease. So then how do we manage these workers? The first thing that we need to do is to make sure that the worker is assessed by their treating doctor. And what the regulation also says, if workers cannot afford a treating doctor, then they have to be assessed by a doctor paid for by the employer. So we want all these workers that are likely to fall in the vulnerable category to be assessed by a doctor. The reason for this is that all of these individuals need to be optimized in terms of their treatment. And if possible, and they're on chronic medication, then get a full script for covering them for chronic medication for the next 6 months, because we have no idea when the epidemic is going to turn, and we'd like to see fewer people pitching up at hospitals or clinics wanting to collect a chronic medication. But that's the first important thing. They have to be assessed by a treating doctor. And what we want to know from the treating doctor is whether, in fact, this worker is actually vulnerable or not. And in a sense, that is all the doctor needs to say to the employer, that the worker is vulnerable. They don't need to provide any details. They don't need to declare whether this person has got hypertension, whether this person's got diabetes, whether this person's got HIV. They just need to state this worker is vulnerable. And if they do, then it becomes a requirement from the employer side, then take action. What we strongly urge is that when the employer takes action, this is based on a workplace policy. It is going to become a contentious issue because different categories of workers are going to be treated, or possibly treated differently. But if it's stated in a policy that is transparent, that is contributed by all the role players, then obviously you have a stronger grounds. When you're making a decision about how to manage this vulnerable worker, the first step that you got to do is, can you eliminate or substantially minimize the risk of exposure of this individual to the virus? Obviously, in certain settings, if you think about a healthcare setting, it's almost impossible to do that. It is possible to do this in other workplaces. It may not be possible to do it in a construction setting. So how would you eliminate the risk? The one way to do it is to say, well, if the operations work through offices and things like that, we locate this individual in an office where they have no contact with anybody that is potentially capable of transmitting the infection. Clearly, this is not going to work in the construction sector on a large scale. So, assuming this does not work, you then need to consider what sort of workplace accommodation you can make. And here we're thinking about, well, can we make sure that this worker gets appropriate protective equipment? Can we consider barrier methods that this worker works at? Can we consider issues that would prevent transmission? So these are the sorts of things that you need to think about. When I spoke about the outbreak situations, if we move in the reverse direction, we know what are the things that are likely to cause people to become infected if they're exposed to an unknown positive case. Close proximity, prolonged duration of time without the use of masks or protective equipment. Now we know that you can't always regulate people to do this in the workplace. Particularly, our work requires us to work together. We're so tuned to working together. And I know Mr. Hunter is going to speak just now about behavioral change. And it's going to take time to get to that. But think back, what are the things that you could do in the workplace that you can prevent people from having this close interaction? For example, staggered working times. So people come to work at different times. Working in groups that allow, smaller groups that allow for separation. Making sure that people don't share equipment unless it's absolutely necessary. Because if somebody shares a piece of equipment that is, and then subsequently turns positive, you got to decontaminate that equipment. And you got to but if everybody was using their own equipment, if this is possible, and you don't allow sharing, particularly of small equipment, handheld equipment. If you don't have sharing, then you don't need to, you're less likely to transmit the infection. And we need to put those sorts of behavioral changes into place at the moment. And then finally, we come down to the issue if you can't accommodate in the workplace, can this individual work from home? Now, this is where I'm saying that for different job categories, you may have different options. And this may become signs of tension in the workplace. A senior manager, for example, can possibly continue to manage what's going on in the workplace, providing he's got efficient and well-skilled junior staff. But the carpenter who needs to be on the work site can't work from home, but yet they may have the same level of risk. So unless you've got this well set out in a policy document, this may become source of contention in the working environment. Then, of course, if people cannot be accommodated in the workplace, if they cannot work from home, then you've got to consider appropriate leave. And to a large extent, this is probably going to require either sick leave or special leave. We then finally come to the issues about returning to work for somebody who is vulnerable. We know that a person who is vulnerable is likely to have had severe infection, and therefore their return to work won't be automatic. They would probably have some residual impairment, and this impairment has got to be taken into consideration in their determination about fitness to work. So that's largely all the things that I wanted to say. I then, just to make a few concluding remarks, clearly, and this was mentioned earlier on today, we have a new world of working. How long we're going to be working in this new world, we don't know. I think it's getting to the point where we can say safely, it's going to be for a long period of time. And if it is going to be for a long period of time, then we cannot wait for this epidemic or wait for the flattening of the curve or wait for the downswing of the curve. We've got to start doing things differently from now. And yes, I know we haven't been doing this in the past. So these are going to be new challenges. For example, FEM wouldn't have been organizing an online conference. They would have been organizing a conference in real life, which would allow us all to interact and exchange ideas. But we're now working in a different environment. We have to do online conferences. We also know that there's a large amount of things that we don't know, and that the solutions that we're putting in place may not be the best, but it is the best that we know at this point in time. But if we all operate basically on the principle of protecting the health and safety of workers in a holistic manner, then I think we're going to be on good ground. And when I say a holistic manner here, it's not just a question of seeing the worker in the working environment, but recognizing that this worker has got to go home, and they've got to be sure when they're going home, they're not taking the infection from work to home to their loved ones. These create a whole range of anxiety and stress, which then in turn influences the manner in which they're able to work in the working environment. It also presents with the tensions that we're seeing where workers are going on strike and demanding closures of workplaces. Also bear in mind that between home and work, the worker has to basically use public transport. If we're wanting to make sure that our working environments are well protected, then we need to focus on how does the worker commute from home to work. Should it be the responsibility of the employer to start saying, well, I need to now think about how I protect my workforce and therefore protect them during their commute from home to work. So those are some of the solutions that you as employers would need to come up with. At all times, we need to make sure that we operate on the best available scientific information. And this is going to change on an ongoing basis. And as you can see, I've already told you about the de-isolation period, which has changed from 14 days to 10 days. And this is based on as science emerges. But there's also always going to be contentious issues. For example, the Ministerial Advisory Committee advised that maybe essential workers go back after 5 days. We in the occupational health work stream at the moment feel otherwise. We feel that based on the available science, 5 days may be a little bit too soon, and we're basically saying that we should retain essential workers up to 7 days before they can consider going back to work. Once again, very big thank you to the organizers. Thanks to all the participants for making yourselves available. And I hope this presentation was of some use to you. My contact details are available on this slide, and I'll be more than willing to consider issues outside this workshop that you think that we will be able to assist on. Thanks very much.
Thank you, Professor Naidu. That was an extremely informative talk. I'm just going to ask you to stay on for a wee bit. Well, thank you to all our attendees for all the questions. We've had quite a few questions come through, and I'm sure you will all understand that we can't get through all of them. What I want to say up front is you'll have the contact details of everyone on here, and the FEM contact details are on there as well. So you're welcome to contact us for any of those questions. Professor Naidu, some of the questions that I just highlighted, just for the benefit of everybody, I know you have covered a lot of this in your presentation, but just to reinforce the message. The first question is, how many symptoms should you have before isolation?
So at the moment, the NICD's set of questions are cough, shortness of breath, sore throat, and loss of smell and taste. Now, if you have any one of those symptoms, you should be tested. And obviously, it's possible that just by using one, you may not pick up a positive case. But we're saying that because of the large numbers of people that we are seeing, then if you're presenting with the symptom, then it is certainly in your interest, in the community's interest to be tested, and then we can make a decision based on the result of an objective test.
Fantastic. All right, then we've got another question here. It says, can we advise other employees of known positive cases within our organizations?
So in terms of our legislation and public health legislation, the answer is yes. The sort of standard laws related to doctor-patient confidentiality in this sort of context gives way to the greater good for the public health. So it is important that we identify those people that are likely to transmit the disease, not because we want to stigmatize them, because we've gone past that point, okay? And I think we need to make this absolutely clear. Any one of us, it is not because you're doing a particular thing or because you are reckless, etc., that you're likely to get this infection. So we should not be seeing this in a negative way, and recognize, if I've got the infection, I tell people that I've got the infection, you need to take action. So it's no use trying to keep these things secret, because this is where the problem comes. I mean, I've got children at school, and the information was a parent of a child tested positive. I want to know, is it possible that my child interacted with that child who may be possibly transmitting the infection? But I'm not told. So all it does, it creates anxiety for my child. It creates anxiety for me, because now he could be bringing that infection home. But if I know that he's had no contact with this person, then our anxiety levels drop down. And that's the approach that we need to take, because clearly what's going to happen, I mean, obviously the school situation is different, but if you've got in a working environment, if it's not clear who was infected and who's likely to have transmitted the disease, everybody's anxious and everybody wants to say, right, I want to stay at home. And then you've got industrial action on your hands.
Fantastic. Okay, another question that's come up is it advisable to transport an employee with COVID-19 symptoms from the workplace in a private vehicle to a nearby health center?
I think that's probably the best way. The one thing that you don't want to do is to say, well, I think this worker is is screened positive and is likely to be positive, put him into a public transport and say, okay, go to a clinic now and get tested. The most responsible way is to say, right, I'm going to now transfer this patient to the nearest clinic using company transport or pay for an Uber. But making sure that the person is masked before they get into the vehicle.
Excellent, thank you. Okay, I'm just going to try and get two more short questions in there. So is the 10-day period based on international standards, or is it something only in SA?
No, it's based on international standards. So the WHO is recommending this and the WHO changed this position sometime in June. And it's clear from the evidence that after 10 days, your ability to transmit the disease has dramatically reduced. So the isolation after 10 days is acceptable.
Okay. And lastly is, can someone who was COVID positive be reinfected after being tested negative?
Yeah, so that's a question that we're still waiting to hear the answer for. And reinfection, there have been studies where they've reported reinfection, but it's not always clear whether it's really reinfection or whether it's just a residual positive test result from the original infection. But I think what we're saying to be cautious is, if you've recovered from an infection, do not assume that you're a superhuman, and that assume that it is possible that you could become positive again, and therefore you still continue to take the precautions that the rest of the community is taking.
Fantastic. Professor Naidoo, thank you so much for your time.
I will go through the chat, and if there's any questions that I could respond, I will send responses to those people that have asked questions.
That's amazing. Thank you so much for that.
Thank you very much.
And for all of you whose questions weren't answered, I'm going to ask you to please, you can forward it to any of the email addresses on there, and we will try our best to answer you. I've got two questions for Jacqueline Michelangelo that I would appreciate. Jacqueline, can you come online? All right, there we go. So Jacqueline, we've got just two questions. I am aware of the time. So the one is, I am a construction employee who travels a lot. The company books me into different hotels, into various hotels in 1 week. So if I test positive, can I suspect the infection from the hotels and claim?
Okay, basically this falls under that category whereby we say is a positional risk. The company sends you from one hotel to the other. You don't have control of your situation. It is very likely that your case will be accepted without even identifying the source. It is a positional risk, and it's also part of the inherent requirement of your job. I hope I've answered.
Perfect. I think that's the perfect answer. And then the second one, just one more for you. I've been receiving a lot of questions from my employees. Is COVID-19 an occupational disease?
Definitely. That is why we do have a circular instruction that I referred to on my presentation. It is an occupational disease, and part of the inherent requirement of the job is aligned to Schedule 3, whereby if you are exposed to an environment where it is likely that the virus is prevalent, you will be accepted. It is an occupational disease, and the form that you need to complete is actually the occupational disease form. Thank you.
Fantastic. Thanks for that, Jacqueline. We will try and ask a few more questions during the course of the day, but I'm really wary of time. We don't want this to go on too long. Okay, I'm gonna get back to our tech team. So I got wrapped over the knuckles a bit earlier. We have a second and third poll question. So Gareth, if you can bring up those questions. And I'm going to read out those questions now, and we'll give you all the results in a minute or so.
Launching poll number 2. Thanks, Herman.
Okay, so poll number 2 Okay, so it's, has your organization been able to comply with COVID-19 directions on occupational health and safety measures in certain workplaces? You can answer those questions now.
Almost 50% have voted.
Okay. Okay, while you're answering those questions, I just want to encourage you guys, we have launched the FEM new website, which is www.fem.co.za. So feel free to jump on, have a look at our website, and you're welcome to give us feedback on that as well.
We're on 63% voted, Herman.
Okay, we've got a 63% voted.
You can just let me know when to stop the poll, and then I can share the results.
Okay, I think we can stop the poll now, and let's go on to, let's share the results first.
Okay, results are shared.
All right, so 95% with a yes vote and only 5% with a no vote. That's great. Are we going to move on to the second poll question, or well, the third technically?
Okay, launching poll number 3 now.
Okay, please indicate, this is a multiple choice question, please indicate if your organization provides the following resources for COVID-19, which is sanitizers, masks, gloves, and soap. Okay, we're going to give you guys 30 seconds for that.
Okay, Herman, that's 30 seconds.
Okay, how far are we on the poll there?
I have stopped it now. I'll share the results.
Okay. Right, so in terms of provisions, we see 99% with sanitizer, 96% with masks, 63% with gloves, and 90% with soap. All right. Okay, we're going to move steadily on. Just from an ergonomic point of view, guys, if you're sitting in front of your computers, feel free to stand up, move around, and stretch your bodies. We're going to move on to our next speaker now, which is Garth Hunter. So he's the industrial hygiene specialist at Engen. Just a little bit about Garth before he comes in. Garth is a registered chartered member of SIOSH. He is the industrial hygiene specialist at Engen. He holds a Master of Medical Science and is a registered occupational hygienist. Garth also serves as a Department of Employment and Labor Government Specialist on Technical Committee 7. He's a board member of the International Occupational Hygiene Association, as well as a KZN Occupational Health COVID-19 Task Team member. So welcome, Garth. I'm going to hand straight over to you, and you're welcome to launch straight into your presentation.
Okay, great. Thank you, Herman. Appreciate that. Let me share my screen. So I'm going to speak on actually culture change in COVID-19 and what that looks like and the implications. It's the third time I've actually listened to Prof. Rajan's actually talk, and I learn more each time, and it was just an outstanding talk, an outstanding platform, I think, to launch really quite a different aspect, which Rajan shared some really important information, and then in terms of how to manage actually COVID. But there's a I'd say the behavioral aspects of it are certainly as important as actually understanding actually the technical aspects. And certainly the two to go together. It's not like you can choose actually, okay, I'm going to focus only on the technical stuff or on the behavioral aspects. Really, you need to actually both have both of these, actually both the technical aspects as well as behavioral aspects actually in control. So, and I've said you can make a difference, and I want to then cover and hopefully you'll get an understanding of how each one of us can actually make a difference, both in our local, in our workplace, in our families, in South Africa. And so what I'm going to go do is, I'm going to take you through is understanding culture, then steps in the cultural observation, and then ourselves as actually culture leaders. So in terms of behaviors and cultures, an important aspect is that you've heard then our President Cyril Ramaphosa actually speak of then behavioral change, need to change behaviors. But if you look at social distancing, how far we stand from somebody else, you can see it. It's a observable behavior. In terms of hand hygiene, you can actually then see whether somebody cleans their hands, whether they use either washed hands or actually use hand sanitizer. You can then see somebody with, and Rajan correctly pointed out that there's a difference between actually an isolation device, which is a fabric mask, and actually PPE, such as your FFP2 N95 surgical mask. But you can still see whether then somebody is actually then wearing that PPE actually correctly or not. And because the good news is that these are all behaviors, and the bad news is that these are all behaviors. The good news is that we can observe them and we can actually change behaviors. The difficulty, or perhaps the bad news, is that we need to change, and we as humans don't find it easy to change. And collectively, each of our behaviors forms a culture. And I'll go into then what culture is, and you'll understand that how really, whether Garth using social distancing, using hand hygiene, PPE, whether then how those are then behaviors and how they form a culture. And then as South Africans, let's ask some questions, and I think some introspection is needed here. And if you look at then some of the Eastern countries, they had MERS, they had SARS, SARS-1, and they were better prepared for actually COVID than actually we as South Africans were.
Hi, Garth. My apologies to interrupt.
Yes.
Do you mind just tilting your camera a bit down for us?
Yeah, sure. Is that better?
That's perfect. Thank you.
Okay, thanks. So do we have a culture of wearing masks? And we don't. We, as South Africans, we've never worn masks collectively as a country. We've then, people at work have actually worn masks, but that's a very, very small minority of people. So whereas if you look at it, and for years actually in China, because of partially actually the smog or the pollution, but also because of actually MERS and actually SARS. So they've been really very far ahead of us in terms of actually culture. Then are we a compliant culture? And all of us have a past, whether we have a past actually as individuals, we have a past then as actually South Africans. And we've had a apartheid past, and the apartheid past was a wrong past. And there was a righteous actually rising up against a wrong. But what did that look like? That meant a defiance. And I'd suggest that something of that defiance, and I don't think I'm overstating it, it's like we call them protests, other people actually call them riots, but we have a lot of social unrest. We know this as actually collectively as South Africans, that we aren't a compliant culture. And I'm talking about everybody collectively as a nation. There might be compliant people, but certainly if you've traveled overseas and you've then seen the compliance. For instance, my wife was in Germany and she looked around and she was going to then cross the road, and she looked around, there's no cars. So she crossed the road, and somebody probably she said about half a kilometer away, saw that she was actually crossing the road and the light was actually red. And this person started hooting at her, bop, bop, in the distance before they even vaguely were close. And the same as in the East, there's a much more of a compliant culture in that people obey laws. In South Africa, we're somewhat lawless. And the reason why the introspection is needed is that in order to then actually effect change, we have to look at where we are now. Because if we out of sync with, we believe something, oh, we're pretty compliant, I do the right thing, and you compare yourself to the standard that's needed to actually then to affect change. For instance, let's say you say, oh, wear a mask, but how do you wear your mask? And I'll cover that in more detail. If your nose is sticking out, what does the virus respect? Does the virus respect a nose that's sticking out? Or does a virus respect something that hands that are sometimes washed? No, the virus doesn't respect that. The virus, any single gap, whether it's actually then in hand hygiene, not wearing a mask, and there's somebody infected, you become infected. And so we're really up against a virus that's actually consistent. And it means that if we don't have a compliant culture, that we're going to become infected. And this actually isn't surprising. And it's not that surprising that I think that we're in the position we are because we need to effect a lot of change. So we ask ourselves as South Africans, do we naturally want to shake hands? Absolutely. One of the things I love about South Africans is we're such warm people. We love to hug and shake hands, and even now people still want to knock elbows or do something. To touch each other, we see ourselves as warm, and we are warm and we are approachable. But is that type of culture we need for actually the virus? So I hate the fact that that you have to change that, which is a really positive thing. But we really have to actually weigh up, okay, do I want to be warm when I'm meeting family? Because and I saw somebody actually then was speaking, I think it was the mayor of New York. He's saying, do we choose to be warm and friendly to our family? And we've seen that big gatherings that people don't wear masks, or do we choose death? Because actually often it is choosing death. And so it really is a case of deciding what's important. And each one of us makes decisions all the time as to what's important. Do I shake hands with then a friend I haven't seen? Or because I naturally, me as a person, I love my friends, I love my family, I love my colleagues, I like to be personable. And yet I have to choose between, do I shake hands, do I warm, do I seem unfriendly, or do I choose death? Do I choose death for me, perhaps? Or if somebody's actually vulnerable, I'm choosing death for them. So these are difficult decisions to make. The other aspect I'd say is that never before has there been an HSE health safety environment risk, which then crosses boundaries between work. At work, I'm safe, I comply at work. Whereas this is an HSE risk, which is going across everything. It goes across actually then what you do when you're going home, when you walk home, is just as important, if not more important, than what you do at work. What you do at home, what you do in terms of social gatherings, is just as important, and perhaps at least as much risk as what you do at work. And so it doesn't, a culture which is compliant on the outside, and we speak of the Bradley curve, where the Bradley curve shows actually then you do it because you comply. Now go back to, I used to be a Department of Labor inspector, and then I did, for a time I was actually at medical school with actually in the same department as actually Rajan. And at that time I was a safety consultant, and I met this lady who was a police lady, and I was doing safety training. I think I was doing health and safety rep training or supervisor training. And this is a big company in Durban. And what she said to me, she said, you know, Garth, she said, everybody only, people only wear the PPE, the hearing protection, only when I'm there. If I'm not there, they don't do what they need to. And as soon as I walk out, they go back to not wearing their personal protective equipment. And you know what? She was right. She was absolutely right. That is exactly the type of culture that they had there. And so by forcing people to do something, you can only achieve compliance at a certain level. And one of the reasons why then I've given up my time today is that I want to make a change. And unless I convince you of the need to change culture, unless you then see and you care and you buy in, nothing's actually going to change. I'll cover some more of that later. Do we have big personal spaces as South Africans? For example, do people naturally stand close or far behind you at the supermarket? And we stand close. If you go to other countries, we've got very small personal spaces. And part of that is that a lot of people have very small houses. We live in, sometimes, some of us are fortunate enough to live in bigger houses, but some people live very closely with each other. And so small personal spaces. So 1.5 meters, that's big. People are naturally used to standing much closer to each other. But now if you take, we don't have a culture of wearing masks. We're not typically very compliant. We're naturally quite a warm people. We have small personal spaces. All these are barriers. And we're not in a good standing as South Africans overall, in terms of everything's kind of stacked against us in a way. And that's why I think we are at number 6 in the world. And our curve's done this, literally. And mostly, that's not a good thing. And then how many years have we done things in the same way? And this is also some introspection is needed in terms of, we might like to personally think that we're open to change. But the truth is, as humans, that it takes us a while to change. I've been learning as Garth to consistently use hand sanitizer, to consistently use masks. It's difficult to change. And again, is that I spoke to Dr. Greg Q, and he said right at the beginning of this pandemic, he says that you need to start practicing the behavior before the storm comes. Now we're in the storm. And if you think you're going to wait until it gets really bad to actually start practicing that behavior, you're going to be way too late. And in a way, that's the reason, one of the reasons why our curve has done this, is I'll wait, it doesn't seem so bad. Nobody's really getting sick. Well, people are getting sick now. And our curve is doing this. So the time to change was actually yesterday and the month before and the month before. But we only find ourselves where we find ourselves, and ultimately we do what we can today. And so we need to change. And then it's not easy for any of us to change our ways. It certainly takes effort. Let's cover then what culture is. And we've been speaking of culture, and the whole talk's really about culture. But one definition is the collective values and attitudes of people in the organization. The collective together. The knowledge, values, norms, ideas, and attitudes which characterize a group of people. For example, if you spoke of, let's say, what you speak of Indian people, you could speak of actually a Muslim group, you could speak of a Tamil group, of a Hindu group, you could speak of Europeans. My wife, in fact, comes from a German background, and they have a very distinct European German actually culture. And when I came into the family, they do things in quite a different way to what I do. And my mom's English, my dad's Irish. And we had an entire, almost the joining of any families is actually then a clash of cultures to an extent. You either have a family culture, that family culture can be a subculture. For example, in Durban, you get a Portuguese club, you get a Jewish club, you get a German club. And so it's not a unified, it's seldom a unified or homogeneous quantity, usually a diversified fragment and split into cultures. That's why you take a culture and you talk about what's the way you do things probably in your house, the way you do things, the way you do things in your house, the way you do things at work, the way you do things at church, the way you do things in KZN, the way you do things, and it's all split. So the culture, to speak about it meaningfully, you have to often actually reduce it. And then ultimately our collective cultures then form the way we are in South Africa. The most useful definition for me, and the one I remember best, is what's culture? The way we do things around here. So the way that Garth Hunter does things within his house or within our house, I have a wife and I have 2 kids. The way we do things around here is our culture. That culture is different from the culture then at work. And so you ask yourself, what's the way we do things around here? What's the way we do things in our family? What's the way we do things then in our workplace? Here's some really good news. And I think this exercise is intended to show that each one of us is actually powerful. And this is the idea of a democracy, is that each one of us has a vote. And we can feel that, well, you could say, what's Garth's vote? Well, ultimately, we choose a government, we choose a whole way of life, which has massive implications for us. 1994, the change to democracy was really about this. It's that each person had a vote and each person got to choose. So in the same way that we can choose the way we do things, we can also change the culture. What do I mean by that? I'm just going to get out of here and show then the screen. Let's say this is a workplace and this is a group of us, and I'll use some people that you just for example, Neil Enslin and Rajan, and let's say this is Garth over here, and Garth has a negative attitude towards wearing his mask. Let's just stick to mask use. He thinks it's actually a waste of time. And how you can change the culture, and you can have a culture of wearing a mask at a workplace, is if you take and you change Garth, you have a talk to you, and that's what I'm hoping to do. I know that I can't change everybody who's on this call, but what I hope to do is to change. I don't know how many of you may change, but if I manage to change the opinion of some of you, that's maybe what success actually looks like. And so if you change, we speak about the need to wear a mask, and previously Garth actually didn't think it was such a good idea to wear a mask. And he said, oh, whatever, and I'm vocal about it. Now, I delete him, you change now Garth's attitude, and the culture shifted from this was equal, first of all. Now from actually having an equal culture, you have a slightly positive culture towards mask use. And here's Gareth over here. And I change Gareth. I speak to Gareth and I convince him that he needs to wear his mask, and we're moving in the right direction. Here's Rajan over here, and Rajan, we speak to Rajan and we manage to then change his opinion. And Rajan now he starts wearing his mask, and he then becomes an advocate. Do you see what's happening? Is that these people over here are starting to become the minority. And let's say we all change. Now, we don't need to change everybody in order to have now positive culture. And previously, some people you just can't change. And I think we need to actually make peace with that. But what will happen if we get an overall positive culture is that their voices become less important. And eventually, even if these people over here, no matter what you say, they don't agree with you, and you don't necessarily have to change them in order to have actually a positive culture. And what will happen, instead of these people actually being vocal, is they change then to just being silent. And sometimes that's okay. And you can still actually then, for example, I work at Engen and our refinery. Even those people who didn't want to wear hearing protection, eventually because of the culture, they changed to using hearing protection, even if they'd still disagreed with it. And the same applies for these behaviors with mask use and hand hygiene and social distancing, and also ventilation. The other one, which is the fourth one, which I really should have put in here, is actually ventilation. I won't speak about today in detail, but ventilation is really important. And actually, just as an aside, is that what a Japanese study found is that if you 18.7 times more likely to become infected with COVID-19 in an indoors environment than an outdoors environment. And that's good news for construction if you're working outside. So your small enclosed workplaces are really, they're the place to worry about. It's not that you can't worry about it outside, of course you have to, but it's really important to understand that indoors is actually a real risk factor. So how do we change to a new set of behaviors? I think it's important, just as I showed the previous slide, that we are all agents of change, positive or negative. We all contribute towards the culture in our workplace, positive or negative. What each one of us has to decide, and I can't force you to change, is that you need to decide whether you're going to then have a positive or negative impact on health and safety or on the culture. Then in terms of, does force work? How do you respond when you're forced to do something? So first of all, you can't force anybody to do anything. People can even choose to actually die rather than actually then to choose to do something. So none of us like being forced, and this goes against, remember I spoke about then that person that was actually a safety officer, ex-policewoman, and she said, well, nobody listens to anything unless I force them to do, unless I tell them to do it, they don't do it. And she was right, it sucks the joy out of the experience. And the other point is, all of us respond to kindness. So if you trying to force people to do something, what's your likelihood of having actually then a proactive culture, a culture where people start to care about each other? For example, if I may wear my isolation device, I wear it as a form of respect to you, and I wear it because I care about you. Now, there was actually a study done in Australia of, I think it was 10 mines, which then showed that the most important aspect or success factor related to actually low HSEQ incidents was people felt cared for. So if we don't if we're trying to say, you wear your mask, whatever, we may get them to actually wear their mask in front of us. But if we do harsh enough, what will happen as soon as then we turn away, they'll just revert back to their previous behavior. And so if you can actually force somebody to wear their mask, you can force them to do hand hygiene at work. But what happens when they go to the taxi? What happens when they're at home? What about those behaviors? And that's the point, is you can't, unless you get a culture of compliance, unless people feel cared for, unless they actually understand and actually buy in, you're not going to win against this virus, because the virus is no respecter of actually then somebody who wears their mask only at work. Wearing your mask at work is probably maybe a fifth of your risk. I don't know, I'm guessing what it is, but certainly it's only a fraction of your risk. So if we respond with kindness, and it's the same actually with, I've got 2 kids, and it's really kind of forcing your kids to do something. So for example, if you force your kids, and you can force them, as soon as they leave home, what do? They rebel. And that's what we need to actually guard against, is that if we have that type of culture at work, where people only do things because they're forced, you are not going to win this battle. And then in order to be effective change agents, we need to choose to be the change we want to see in the world. So we need to also lead from the front. And we need to practice those behaviors. And I don't know, I'm not trying to bring any political affiliation into it, but look at President Trump, and look at when you're telling other people that they must wear their masks, but you then choose not to wear your mask. How well does that go down? So what I'm suggesting now is that we can actually, through some very simple steps, and people don't have to understand that we're even doing this, is that we can actually then affect change. And there's different steps to this, is that the first is actually then, if you're going to have change in the workplace, is that first of all, empower yourself. So what Prof. Rajan has spoken about earlier on. I'm not going to cover that in more detail, but you understand actually then that a cloth mask is the isolation device. You understand what the difference to PPE is. And that's why make sure that you empower yourself and you understand what the basic barriers are. It's also worthwhile understanding more about ventilation in order to be able to actually control your workplaces. So I'm not going to cover these, but you need to really understand the difference. When do you wash your hands or use hand sanitizer? What's the reason for social distancing in terms of like droplet spread or aerosol spread? And what does that even look like? And for example, a lot of people don't really understand actually then what social distancing actually looks like. If you say, how far is 1.5 meters? People won't understand that. And so why do we practice that? If you understand how far droplets go, then you can understand how far or why you use social distancing or why social distancing is effective. What social distancing you need when you're running, for example. If you're running, actually the plume you create behind you can actually then spread. I was reading, if you're running fast, they say that then you need to, if you're jogging, you need to keep a 10 meters behind somebody else. If you're running fast, they suggest, the German study suggests keeping it up to 20 meters distance between you and somebody else. So we need to understand and equip ourselves with knowledge. Then the next one is an EQ, emotional quotient or emotional intelligence. Is that, for example, there's this cartoon over here. If we said, I was speaking to, let's say I was speaking to Roger and I said, oh, I've got hundreds of Facebook friends I've never met. And he said, oh, when I was young, we used to call them imaginary friends. How would he take it? And if you're speaking to me and saying to me anything after that, how would I take it? And the point is, he wouldn't take it. And so we have to use some questions here. We have to use some emotional intelligence. And first of all, do you have a relationship? It's an important, in order to speak into somebody's life, in order to give them information, you have to ask whether you've got a relationship. If I went and approached somebody in the, let's say in the shopping mall, and I spoke to them and said, oh, you must do this, this, this. I say, who are you? Who are you? And do you have authority? Is your influence welcome? All of these are important questions. And so for each different person, for example, the way I speak to different people isn't all the same. With some of my friends, I've got quite robust relationships. If I spoke to my wife in the same way, even joking, it wouldn't necessarily be welcomed. So just, I think, being in relationship with others, it should teach us then, how do I approach this best? If I'm speaking to one person, I speak in a different way, maybe to actually speaking in larger groups. But ask yourself that question in terms of what group it is, how you speak to them. And then if you're speaking to somebody about, let's say, mask use, allow the interaction to be a normal conversation. You don't say, well, actually, I'm doing a behavioral observation. You chat to them about it, speak to them about it, smile, be friendly about it. You've got to make sure that they feel that you care. If they don't feel that you care, you're not going to get very far. Then in terms of listen for understanding, and this is something which I'm still in a journey to listen well. I don't think in fact, if you ask my daughter and ask my wife whether I listen well, they say, I'm not a very good listener. I'm trying though. I really am trying, but it certainly is a journey for me. And I think I'm getting better. Although, yeah, so we're all on journeys. And so I'm also on this journey with you. I'm still trying to change and still trying to become a better listener. So this might be an old person. And if you said, why you, oh, put on your mask, you're wearing your mask with your chin sticking out. You haven't asked that person where they got their mask, whether they had money to get a mask. Perhaps somebody had to buy their mask for them, now given it, and that's the only mask they have. Maybe the kindest thing you could do is to actually ask them why, but listen with empathy, listen with caring, try to understand actually why they're wearing a mask with with their nose, chin sticking out. Also be gentle, be kind, smile, be kind. So we need to listen to others, first of all, before we can offer advice. And by jumping to the reason for the non-compliant is a little bit like that police lady where she assumed she knew why people were doing something. So this is a checklist for probably for Garth and perhaps some others, is pay attention, listen with your body, don't interrupt. That's critical. Interrupting is disrespectful. And this is hugely about respect, because actually wearing my mask is a sign of respect for you. Washing my hands is a sign of respect for you. And that's something that we do have in our South African culture, which you can speak to, is we can reference respect and what respect looks like. Repeat what they've said and respond to what they've said. So it needs to be a discussion. This is not a telling you. Then feedback. Feedback is not a time for personal opinion. It's speak about then what observable behaviors would you involved, because often people think they know the answer and they give me they think they know the answer, but often they're wrong. What's your mask is around your neck? That would then saying why is that? So you'd speak to that. And the biggest mistake we can make is to talk too much. If we're doing an observation, we're doing, and even this conversation now, it feels, a webinar often feels to me that I'm doing all the talking. Of course I am. But I feel then, oh boy, Garth, you've been speaking a lot. But we shouldn't get that sense when we're speaking to somebody. If we're doing all the talking and they've been pretty much hardly get a word in edgeway, we're not going to make a change. And then also that it is a time to speak about respect. You know that I'm wearing my mask for your protection. And not making you wear your mask makes me feel like you don't care about me. So it's that also have a discussion. Let's say I spoke about earlier on. It's often it comes down to a choice of not wearing your mask is one choice, and death with COVID-19 is the other choice. And if you speak about, then you humanize it. That you speak about, well, actually, do you know that actually I've got somebody at home, and somebody actually then said to me who's got stage 4 cancer, and now you're expecting me to go home and you haven't wearing my mask. You don't know the people who rely on me. You don't know what my family, in fact, somebody actually called me, spoke to me and sent me a mail with an engine. And they said, yeah, I've got actually, my wife has got stage 4 cancer. My mom is actually then got, she was also really, really sick. And can I be safe at work? Now, if you're not wearing your mask, you don't see those people behind me. You don't see what effect it actually has. Unless people feel cared about, we enter into conversation as to why we should do things. It means that when they get to the taxi rank and they come to work then, and they haven't been wearing masks, haven't been using hand hygiene, they're bringing that risk into the workplace. And then they're placing me at risk. So this is really it's a deep case of respect, in that if we are to respect each other, we'll actually comply. That's why we're doing it. I offer that compliance. I don't demand that compliance. And I think that that's the difference, is that we have to speak to people in a way in which they can see where we're coming from. If they don't see where we're coming from, where my heart is, they're not going to change. And so this process has to actually take that in consideration. Find the good. And this is important, is that any feedback, try find something. Yeah, they might have their nose sticking out, but what you did was that you're wearing your mask, but what you can do even better is keeping your nose in. In fact, it's strange. I see people all around, and we seem to have adopted then a culture of, well, actually wearing my mask with my nose sticking out is okay. Actually, does the virus respect the fact that your nose is sticking out? People wearing masks on the tip of their nose, how many people have you seen like that? And the virus doesn't respect somebody whose nose is sticking out. It doesn't respect somebody whose tip of their nose is just covering the tip of their nose. So it's not just about compliance. In compliance for COVID-19 isn't good enough. We need to actually then adopt barriers which are intact enough. And when I speak of barriers, I speak of wearing a mask, hand hygiene, social distancing, ventilation. Think of those 4. And I need to have those barriers intact. It's not just about compliance. It's about making sure those 4 barriers are intact and remain intact. And only by keeping those barriers intact, it's James Reason's Swiss cheese model, where you need all these barriers intact. And what happens when you actually don't have good ventilation? You don't have good hand hygiene. You're not wearing your mask. You're not maintaining social distancing. When all of those barriers are broken, your likelihood of actually then having COVID infection is sky high. And if you look at us as South Africa, how did we move to 6th in the world in such rapid, with a curve that looks like this? Is we did it because actually many of our barriers as a nation are actually broken. So finishing the observation, encourage the person at the end to feel good about the observation. So as COVID leaders, lead by example and influence, not by position. Be kind. Ask questions first. Find out what the problem is in the workplace before giving direction. And another thing is consequence management. There is a place for consequence management. That is disciplining somebody who's not complying. But it shouldn't be, if I was trying to sell Nike shoes and it was all about threatening people, if they didn't do this, then this is what I'd actually do. I wouldn't sell very many Nike shoes. And so our whole HSE marketing should be positive. It should be that we're actually sell a good message. Somebody who's not compliant, that 1 or 2 people, remember the positive negatives? You take them in the back room and you actually then speak to them, and if necessary, discipline them. So I'm not saying there shouldn't be consequence management, but it shouldn't be the upfront that people, your first thing you do at your workplace is want to threaten people. You might need to actually take consequence management, but it's a minority. And also do what's doing right and try to make the experience positive. I think I'm pretty much time up. So with that, I'm going to stop and maybe let me just finish off by just summing up, is that we need to change our culture as South Africa. We can change our culture, but you need to be a culture leader within your family. If you're not being a culture leader at the family, how are you going to then, if you can't manage it within your family, how are you going to manage it at work? If you're not being successful in being an influencer within your family, within whatever group, your church group, whatever group you're in, how are you going to affect it at work? That each one of us is powerful. And what I hope to do today is to have actually convinced you that you can be powerful. And you just need to change, and perhaps you just change one person. But by doing that, and if all of you on this call all took that message home and you said, we're going to make a change, we could shift the needle in some way. The more people we speak to, the more people we convince of this, the bigger the effect we can actually have. Conversely, and I also know that within this room, this virtual room, it's a little bit like that positive negative, is that there are some people who just don't get behavioral safety. They will always be the negative ones, but I'm not speaking to them today. You need to decide whether you're that person or not today. I'm speaking to the person who perhaps was negative, can become positive, and I'm hoping to make that change. And so I'm encouraging you, take this back into your workplace. Take it back to home. Take it back to the taxi. Make what effect you can. Be kind when you speak to people. Think, promote that culture of Ubuntu, promote that culture of respect so we can actually make the change as a nation that we need to. Thank you so much.
God, thank you so much for your time. That was really, really informative. Okay, so I've got a little issue. There we go. Okay, it was really informative. We really appreciate your time. We are running over. I do have a list of questions. I'm going to ask you just one or two, and I'm going to ask you to be very brief in your replies,
sure.
Please. Around the culture, now I know your last slide covered the management. What advice would you give to managers? I know there's been a lot of people painted a few scenarios, and if you look at the workplace, a lot of people are very fearful of not complying at work or not going to work, and it comes out in terms of management that managers are forcing people to work. What would your advice be in terms of culture and in terms of management on work sites?
Just repeat that. I just want to make sure I answer the question in terms of advice to managers.
Advice to managers who are enforcing people to work, essentially.
Forcing them to work and forcing them to actually then keep controls in the place is actually different. So the question is that in terms of making sure that the controls are in place, what I'm saying is that there needs to, first of all, be a plan. There needs to be resources behind this. To believe that you're going to just actually then have it as an individual and you kind of feel good and you're going to try and make a difference is not good enough. This needs to be a well thought out plan. What are you going to do in terms of your communication strategy? Who's going to handle that? Who's going to then put, say, sessions together? And you need to resource this properly. That needs to be with any plan. For instance, in the construction industry, you probably have a Gantt chart and you have different activities and you run those activities. So what's your plan to actually affect this change? And that's what I'd say, is that you need to be intentional about it. You need to actually understand it. Another important point is that you need to lead from the front. So for example, at the refinery, we had Wayne Hartman. It starts actually from the CEO. The highest person in the organization really needs to take that ownership, and they need to send out the message that we want to make a cultural change. And so what we did was the CEO, actually, they lead the first session. And the person who's changing the most in that session is the person who's leading that session. They then roll it out then to the people below them, and they roll it out actually then further and lower down. And one of the ways we did this was we actually then did different scenarios. For example, you can play out different scenarios that actually around COVID. And it can be as simple as actually taking a photograph and presenting or showing the photograph up there. It could be a virtual room or a site where you just show a photograph, and maybe actually having taken a photograph on your phone is fine. But getting people to speak around that and listening to them and allowing people their say. And actually, if the CEO did that and he presented to his managers, they present to their managers. And by doing that, even the manager who doesn't want to or doesn't believe in this, he wants to please the CEO, which is sometimes enough for him to actually buy into this. So even people who don't naturally take to actually behavioral safety to cultural change will buy into it. So it needs to be a very thought through process.
Just one more. I see this has come through a couple of times around funerals. Now, from a culture perspective, the questions are what happens if I go to funerals, and what are the preventative methods that we can take? Do I self-isolate? So there's been a couple of questions around that. Is there any advice from that perspective?
So of course, it depends whether you're organizing the funeral and you have any influence over what happens. And if you do, I'd say that you have a moral responsibility, if you do care about the people at the funeral, to take precautions. The second one is that it's to be intentional about thinking beforehand. For example, our CEO was actually planning to fly, and we did a formalized risk assessment, looking at the different barriers and seeing how we could put those barriers in place. So, for example, are you going to give into the social stigma of actually wearing your mask, taking your mask off, other people are there or not? And are you going to then use hand hygiene? Are you going to take your sanitizer with and use it? In terms of then social distancing, if I view it as actually then a type of defensive driving, that I'm aware of my people around me, actually who's where and where they're coming from, have a look and see if there's anybody coughing or any symptoms. But I manage and look at identify my controls. Is it indoors? If I can choose to stand outdoors, actually instead of indoors, I do that. If I'm close to an open window, I choose to do that. So there's a lot of things here that are in our control in terms of each of one of those barriers. And I suggest that if you're going to the funeral, be aware of those and be intentional about actually keeping those barriers in place. We become infected with COVID-19 when those barriers are broken and actually they're not maintained.
Fantastic. God, thank you so much. I can't get to the other questions right now, but
Sure.
if we do have some time a bit later, I might call you back to answer those.
Great.
Okay, moving straight on. So the next presenter we have is Neil Enslin. He's the Health and Safety Manager from MBA KZN, and he will be talking to us on COVID-19 challenges on construction sites. So just a little bit about Neil. Neil Enslin is the Occupational Health and Safety Manager for Master Builders KwaZulu-Natal and has served the association for more than 15 years. He started his working career with Mondi Craft in 1994 and completed his N4 paper achieving qualification. In 2000, he changed his focus to safety risk management and later qualified as an Occupational Health and Safety Risk Management Officer. He obtained his National Diploma in Safety Management in 2005 through UNISA and is a registered professional construction health and safety agent with SACP CMP, a chartered member with SIOSH as well. Okay, Neil, if you're ready, I'm going to hand over to you. Welcome.
Thank you. Yeah, thank you for that nice introduction, and thank you for the opportunity to speak to both SARS and FEM policyholders and some of our own members in this various associations that form part of Master Builders South Africa. So I just would like to disclose up front that the findings that I'm sharing with you is based on personal experience, as well as some experiences shared by our Master Builders Associations Federation, the likes of FEA North, Western Cape, Eastern Cape, Boerland, etc. They shared their experiences in preparation of a technical committee meeting that I had to attend to share what challenges we're currently experiencing within the built environment and specifically the construction industry. So what I did was to come up with an audit system based on the COVID-19 directives. If you look at the sectoral codes at the back of that document, I basically then did a quick audit system, and then I went around auditing both from a client perspective, but also from a membership perspective, and provided them with feedback. Many of you might have seen Thibaut Zana, the Chief Inspector's little YouTube video recently, where he disclosed that the compliance level is around 57% across all sectors. I will, to a large extent, agree with him. I think that is what it was initially. I think it's slowly but surely increasing as people understand how to apply the directives and how they're seen. So these are basically where we are today regarding COVID management in construction. So let me just start off by an opening remark. So over the years, we were mainly focusing on the health and safety component of things rather than the health. And now with COVID-19, it is prominent than ever before because of other health issues within the built environment, TB, employers with TB, HIV/AIDS, substance abuse problems, as well as we're working with asbestos, noise, and saliva. So we're obviously seeing now that COVID is exacerbating our vulnerable employees, as our previous speakers alluded to, and managing them that. So even more so now than ever, we need to also look at the health part of things, primary as well as health on site. So I will be dealing mainly with the challenges that was experienced with the implementation of return to work protocols. This is mainly of the level 3, not so much in level 5 and 4 where building was taking place. They had different regulations that they were managing themselves under, but more so after the June reopening of construction site. Obviously, a major issue was for contractors was the cost of site closures due to a positive case, to clean the site again, the lack of understanding of a smaller contractors relative to COVID-19, the long-awaited sectoral guidelines that were drafted and still not published by the Department of Employment, medicals, the spider testing in particular, and the impact that will have going forward. And then obviously we have historically had 3 challenges in our industry. It's transport of workers, still remains a concern, welfare facilities, and then the provision of protective equipment. If I now go and just break down each one and by line item, implementing of return to work protocols were challenging for contractors, and that employees were not that keen to do self-assessments prior to arriving on site. And that is understandable considering the length of time that everyone was on lockdown, and some of them probably did not earn a living at the time, so they were keen to return to work and start their lives, livelihoods and earn a living. And it's been a challenging for that. So people don't always disclose how they feel all the time. So as the Prof alluded earlier, the screening ability needs to be stepped up at entrance of sites, because the behavioral screening of just the temperature can be passed depending on the temperatures in the environment you find yourself, Gauteng versus Western Cape versus KZN versus Bloemfontein. And there's major differences in temperatures at 7 o'clock, up to 7 o'clock in the morning versus and that. So yeah, it's very important. Then obviously getting subcontractors, similar scenario with subcontractors, they have also felt the rollout of these long extended lockdowns and the impact it had on its businesses. And obviously they're also slightly reluctant to come up and tell you when they have problems on site. So that's another problem. Then if you look at return to work protocols in terms of those sectoral guidelines that were published in the directives, I further then dissected each return work plan that is available on site. And I must just remind everyone that during this COVID virus, that we need to ensure that often the construction continues as normal, but the COVID blankets it now. So it comes over the construction health and safety protocols you have, and when time gets to a stage, it will move away and will continue construction as normal. So your normal health and safety protocols remains as it normally would be. You just intensify the manner in which you look at COVID now. So again, we find that some of the guys struggle to show you how do they report symptoms by an employer and employer. So obviously they weren't too familiarized with how to report cases. And I'm not talking through the hotline, but just generally setting up protocols within the workplace to get employees to come to them and tell them that they're showing signs or have signs of COVID-19. So again, it's similar to your normal, how do you report injuries and incidences on site? So you just have to elaborate and include COVID. So you will continue to see that COVID needs to just slide in here and it becomes a blanket, and then it moves away as when we're out of this problem we currently experience. Reporting of incidents, obviously our previous speaker has dealt with it from FEM, how to report the incidents, the types of forms that need to be completed, the methodology around that to ensure a successful claim, and obviously not to delay any claims as a result of that. Then also although this is not directly a requirement, but it's a good practice, is to see if policies are updated to make reference to COVID-19. Very few employers have actually updated their policies to reflect COVID-19, as well as when it comes to their visitors and how they manage COVID-19 in the workplace. But that's like I said, that's not a legal requirement. That's just something that's worth looking at if your existing policies to amend it. Then obviously the route of exposure clearly defined, and that's obviously as the professor alluded to, especially when you come to a case we need to close sites down, you need to be able to identify where and what is happening at any given time and the level of exposure relative to your risk assessment. So again, that will help you whether to do a partial closure of site or complete shutdown and the length of time involved. So it's very important that you guys look at those kind of things throughout the life cycle of a construction site. Then obviously the whole issue around special measures to cater for vulnerable workers. We know that our workers are vulnerable, are suffering from various medical and comorbidities disorders, and we need to identify through proper protocols that have been given to us through the guidelines, as Professor has already alluded to. And he's covered a lot of my presentation and his on how to manage things. You need to go and look at that and make sure that you cater accordingly for those, and that's in your workplace. Then obviously social distancing is a challenge on construction site. The 1.5 meter scenario doesn't always apply to the industry, and it's very difficult to maintain. So again, when I saw some people asking about various guys climbing on working at heights with face cloths, etc. Again, when your social distancing cannot be applied, you need to do a proper risk assessment and find alternative measures then and including PPE. I think the notion at the moment is because the guy's wearing a face cloth, that is good to go. We must not forget that we're still working with inherent risks on site that we need to manage accordingly. And when you're dealing with those type of work, whether you're sweeping a deck, where there's dry cement, you still need to wear the appropriate PPE. You do not stick to the current 2-ply face mask. So please remember that when you do that. I think there's a lot of confusion around that. So yeah, if we move on to the next one, is about the site closure due to a positive case and the deep cleaning process. Obviously, the deep cleaning of the positive case will depend on the work that I said earlier on, and making sure you can group people, you rotate them in terms of timing, and you stick to the same structure. So if you're a scaffolding group, keep the scaffolding group together so you know that where there are carpentries, etc. But it's very difficult on a construction site. I'm aware of that. I'm sure people's going to say, but Neil, how do I do that? You do have to try and manage it and look at your programming relative to what you're doing and try and adjust it and see if you can amend it accordingly. But yeah, it's obviously contact tracing becomes part of the whole process, as we all familiarized with, to try and get those that are affected by the positive case on site, and then the impact on staff involved. So obviously there's a moral and a physical, psychological impact, and we need to manage that accordingly as well. Now we're going on to our smaller, medium subcontractors that make up probably 95% of all construction sites, and their lack of understanding when it comes to COVID-19. Obviously, not many of them are privileged to health and safety professionals within their current setups, and they therefore either make use of consultants or they try and do it themselves through the various associations or bodies they belong to. But it does pose challenges. And obviously the main one, and it was addressed during the technical committee, about the level of compliance in terms of consistency. We do find a lot of inconsistency and different interpretations. So now we're in a new way of work, and people interpret things differently. So these small guys that work on 5 to 6, 7 different sites within a particular metropolitan or municipality, or wherever they find themselves, find it very frustrating when they go to one contractor to the next, and the stuff is not, there's no consistency. They are being asked for different things all the time. So as we plead to the main contractors as well, just to create a bit of consistency within your national or your bodies you have, so that when you have these subcontractors working for you, it will be much easier to manage them accordingly. So those are the challenges that are experienced under the smaller guys. Obviously, the sectorial guidelines drafted are still not published. We did raise that concern. It will help the smaller guys to how to implement and manage COVID-19 from that perspective. We did get the assurance that they're working on it. There were some issues within the department that they didn't want to disclose the reason behind that. What hasn't been published, but for now, it is still pending, and we're waiting for it as everyone else is. Medicals. Most of us, we know that we need to comply, ensure that all our staff that are on site have a medical fitness to work. And during these times, one of those tests that are done is the spiro testing, or the lung capacity, and various bodies relative to in the medical field. And even Prof, I consulted the Prof on it some time ago about whether or not it's good to continue with that in the general. And it was overwhelming. We were told to stop immediately, do spiro testing at this stage. Now, the challenge with that is twofold. One is the later complications of potential COEDA and FEM policyholders claiming for issues surrounding chest-related or lung capacity issues. And the other problem is that the industry are now starting to look at alternative methods of doing a test related to lung functions, and that's now also X-rays. Now, many of you will be with me on this boat, is that we've seen a lot of articles and a lot of bad news, so to speak, that our industry is at the verge of collapse. So by clients adding on X-rays as an alternative to Spiro at this stage of the fight, so to speak, is not going to help our industry. It's going to deplete it even further. So there was a lot of concern around the additional cost to X-rays in that regard. So we did speak to the technical committee through Pumi and Puma, and they assured us they will write to Tibor, and we did it ourselves to get that matter resolved as quick as possible and sent out a national circulate on whether or not the exemption will be given, and then obviously everything attached to it. So there's a bit of consultation that needs to take place between this, the various departments within the Department of Employment and Labour and COIDA in order to get that finalized and tell the industry what to do there. So we have been on that matter on a regular basis, and we're waiting patiently for that. So as soon as something is available, it will be circulated through all the platforms, SARS, the various associations, FEM, etc., so that you all understand what's going to happen there. So now we're looking at historical challenges we've had in the industry, and it's coming to the forefront more and more so. And obviously the transportation of workers have compliance have always been an issue. We've had high levels of motor vehicle accidents in the course of employment, and now with social distancing and all the requirements attached to transporting staff and using public transport is further increasing the risks to an employer when it comes to the employees reporting for duty. So we're still going to have a problem with transportation going forward, and it is a challenge for all. And we've already seen that the capacities of public transport have been increased to 100%. So the risk of infection through our staff using that is going to obviously spike, and it's probably a reflection of what's happening currently in Gauteng and slowly rolling out here in KZN. So yeah. Then welfare facilities, we all know that's been a major challenge for our construction industry over the many years of existence. Being able to give proper toilet papers, wash basins, and that. So again, from a hygiene perspective, having guys to wash hands regular with soap and water, it's going to remain a challenge unless we allow for provisions within the bill of quantities for that. So again, it will be a combined, as we'll see in my way forward to manage these things, is that it's a collective approach that will have to be made in order to ensure that everyone involved can get the best hygiene facilities during COVID. And then obviously PPE, we always know that there's always been a major issue with PPE compliance in the industry in general. Again, this will COVID will again bring this to the fore, and obviously that we need to make sure that through our provisions of health and safety in the preliminary of bill of quantities. I know it's difficult on existing projects. We feel that several calls regarding that, and we've made certain articles available through our building expert here, Ross Steenberg, that's written on how to do it through the various JBC contracts on existing projects. And obviously, most of the new projects going forward will have allowed for COVID-19 measures within the workplace. So the way forward, so we need to ensure that clients do apply baseline risk, and designers consider it, etc. is included in the specifications, how to deal with it. Designers of design hierarchy should consider COVID issues. Designers should look at alternative methods, highlight the residual risks that are posed within that scenario, and clients should be amending their specification include for COVID issues, as I already do it through a bill of quantities. Contractors, then obviously as a result of that, will have to ensure that their plans are appropriately covered COVID-19 measures through their safe work procedures, their safe work operating procedures, their safe work procedures, as well as their hierarchies. So again, it will be, as you can see, it's a multiple stakeholder approach. It's not a one-side affair, although historically it's normally left to the contractor to survive and fend for himself. But it's clearly we can't continue on that. So we need to ensure that COVID it's not just a site issue, but it's a project issue that requires a coordination of multiple stakeholders, as I already alluded to, through project managers, principal agents, in the way it's delivered, its designs, its procurement, its contract construction monitoring, etc. And that's why it's important to, we as agents have cried for some time now to be included during these initial stages of stage 1 through to 6 to ensure that we can adequately address now even more so health and safety matters, but particularly the health part of it in COVID-19. So yeah, let's see and hope that that will plan out as time goes along, and whether this will come to the fore. We hope that this will be the case. In conclusion, just to wrap it up, as I said, COVID is a reality that we'll have to manage by all the built environment stakeholders upon recommencement of construction. COVID is likely to last the last virus that humans and the built environment will have to contend with. Therefore, strategies, systems, procedures, protocols, etc., will have to be looked at. Oops, sorry. And legislation and regulations providing for framework to schedule the minimum requirements. So we still, again, with self-regulating, it's just the minimum. We need to make sure, and then obviously we'll look at best practices. And then, as I said, this whole problem is not just a contractor problem, it's collectively. Before I hand myself back to Herman, I just like to play you guys a induction video that the association created during the lockdown period in 5 and 4. It was challenging, but we felt it was the need to try and help the members in the KZN region to help them with the induction in particular. We also set up a protocol on our website at masterbuilders.co.za. You go there and you'll find all our bulletins relative to COVID-19, health and safety, contractual, best practice, anything related to QERA matters, SARS matters, whatever the story we have experiences during this time. It's available there for you. So I'm going to play you this short induction DVD. As I said, it was done remotely with very little resources at the time, but I think that the crux of it is to get the message out there, how to help our members. So there we go. Let me just.
Sorry, Neil. Is there sound to your video?
Yeah, okay, it's fine. I'll make this video I don't have it playing through the normal thing. It's playing through my my laptop here. So apologies for that.
Oh, no,
it is available on our website for free download to those who would. And as I said, it covers the 8 BCs of management of COVID on construction sites and those that are in attendance here.
Apologies, Neil. Yeah, if you would like to share, you can stop your share, and before you share it again, at the bottom left, you can just tick share with sound before you share. So you can unshare, and you can just try that for us if you don't mind. Thank you.
Stop share. Okay.
I'm sure a lot of the attendees would like to view that video.
Okay, so you just like Gareth, apologies, just talk me through to that. So obviously I'll open it up again.
Click on your share screen button, and on that window at the bottom left, there'll be a little tick box that says share with sound.
Okay, I got that. Thanks, Gareth.
No problem, you can try again for us.
Yeah, let's see if we can get this to work.
The COVID-19 pandemic has given rise to a heightened
priority. Just make it full screen for us, please, Neil.
Health and safety measures on construction.
Let's have to go there. Apology. There we go. Let me get.
The COVID-19 pandemic.
Sorry, man.
The COVID-19 pandemic has given rise to a heightened priority to implement additional occupational health and safety measures on construction sites throughout South Africa. A risk assessment has to be conducted and site-specific measures established with all necessary products and equipment required for the proper implementation thereof. It is also essential that employees are given instruction on how to effectively apply the measures identified by the risk assessment. This safety induction video clip is brought to you by Master Builders KwaZulu-Natal and aims to provide a visual guideline on how to keep your construction site safe from infection. The World Health Organization has listed fever, fatigue, and dry cough as symptoms most likely to be experienced first. Other COVID-19 symptoms may include muscle aches, nasal congestion, sore throat, and in some cases, diarrhea. If you or anybody else on site displays any of these or other flu-like symptoms, it should raise an alarm to the possibility that they may have the virus and ought to be tested as soon as possible. If an employee presents with symptoms of infection, the employee must be provided with a new surgical mask and must immediately be separated from the rest of the workforce. Arrangements to have them assessed at the nearest appropriate medical facility must be initiated. If the person tests positive, workstations, tools, and equipment that was utilized by them must immediately be disinfected. Contact tracing would have to be conducted in the affected person's work area to determine if they came into contact with any of their co-workers. If it is determined that an employee has come into contact with somebody who has tested positive for COVID-19, that employee should also be sent for immediate testing. During this time, they should remain in isolation until the test results are obtained. If a person contracts COVID-19 during the course of their work, the Department of Health and Department of Employment and Labor have to be notified. They will then assess the severity of the situation and implement whatever decontamination protocols they deem necessary. Every person can make a difference in preventing the spread of the virus by following these simple steps. Wash your hands frequently with soap and water for 20 seconds. Use an alcohol-based hand rub if soap and water are not available. Wash your hands after sneezing, coughing, wiping a child's nose, etc. Wash your hands before eating or touching your face. When using an alcohol-based hand rub, apply liquid to the palm of the hand. Cover all surfaces of the hands with the liquid and rub hands together until dry. No shaking of hands on site. No sharing of food or drinks. Cover your coughs and sneezes with a tissue, or cough and sneeze into your elbow or upper sleeve. The virus spreads when liquid droplets are expelled through the air by coughing or sneezing. Throw tissues into a no-touch wastebasket. Clean your hands after coughing, sneezing, or blowing your nose. Avoid touching your eyes, nose, and mouth with unwashed hands. Disinfect or wipe down your workstation, locker, or change area. Practice social distancing. Where possible, keep at least 1.5 meter distance between yourself and others. Have a strict cleaning regime. Routinely clean frequently touched surfaces on site, such as plant equipment, railings, and toilets. Use the cleaning agents that are regularly used in these areas and follow the instructions on the label. All tools on site must be wiped down before, during, and after use. Always wear a face mask. Before putting on a mask, clean your hands with an alcohol-based hand rub or soap and water. Place your mask carefully to cover mouth and nose and tie securely to minimize any gaps between the face and the mask. Masks must fit properly, ideally covering at least 50% of the length of the nose and fit to 25 millimeters under the chin. Avoid touching the mask while using it, and if you do, clean your hands with an alcohol-based hand rub or soap and water. Replace the mask with a new one as soon as it is damp, and do not reuse single-use masks. When removing the mask, remove it from behind. Do not touch the front of the mask. Discard immediately in a closed bin. Clean your hands with an alcohol-based hand rub or soap and water. To mitigate the risk of COVID-19 exposure, the following precautions must be taken when traveling. Social distancing should be maintained while traveling, and passengers should always wear a suitable face mask. Keeping vehicle windows open with passengers facing away from each other will help reduce the risk of transmission. Consider alternative travel arrangements where possible, and those who can use their own transport should do so. All vehicles should be cleaned regularly using gloves and standard cleaning products, with particular emphasis on handles and other areas where passengers may touch surfaces. When utilizing public transport, ensure that you take extra precautions and have adequate PPE, including a suitable face mask, and maintain social distancing. Frequently clean hands using alcohol-based hand rub or soap and avoiding touching eyes, nose, or mouth. Ensure that you wash your hands and sanitize properly on arrival at the workplace and when you return home after work. Remember that we all have a collective responsibility towards fighting the virus, no matter where we are. So do your bit. Thank you for watching the Master Builders KwaZulu-Natal site induction video clip, helping you to prevent the spread of the COVID-19 virus on construction sites. Stay safe.
And thank you, Chair. And that concludes my presentation. Thank you very much once again for allowing me to chat to you guys.
Neil, thanks so much for that. It's a great video. Appreciate it. We have run over our time. It's 12:35. I'm just going to ask you two very quick questions, and I'm going to ask you to be as brief as possible. Can a safety officer appointed on site also be appointed as a COVID-19 compliance officer?
Yes.
Perfect. And are face shields acceptable instead of cloth face masks?
Again, as I said earlier in the presentation, it's your risk assessments relative to the activities will determine the requirement. So if a face shield is then deemed the better option at the time than the face cloth, then obviously that will be your preferred choice of PPE at the time.
Fantastic. Neil, thank you so much for your time. Really appreciate the presentation. And
welcome, sir.
To all our panelists, once again, a very big thank you from all of us at FEM. To all the attendees, thank you for attending, and a big thank you to Niels, Sash, and Gareth, the tech team that are 600 kilometers away. I think you guys did a fantastic job. And to Sanjay for putting this whole thing together. We trust that you guys will stay safe and have a great day further. So to everyone, thank you for joining us, and goodbye.